I know I say this every week, but hopefully that's a straightforward meeting. So we will just begin then. Apologies. We have apologies from Alan Chambers, MLA, and anybody aware of any other apologies? No. We obviously also have Linda, Danny, Alan, and Orlia joining online, and 3 of those are already online.
Excuse me.
Okay, so Chair's business, just to inform everybody, there's an event on the 22nd of September, 11 a.m. to 12:30 in the Long Gallery. It will be an opportunity for members to get the MyCare app downloaded and hear more about the MyCare system and to promote the system. So it was an idea that we had come up with in our meeting too, when we got the briefing on all of that stuff. So I mean, MyCare, I use MyCare, and I'm a good advocate of it. I think it's very handy, and obviously the more it gets developed. So we just want to make the population at large, through a bit of publicity on Monday, aware that it exists and they should be downloading it. The other thing, just to point out, myself and Colin was there. We attended an event up in Carrickduff yesterday, sponsored by the Royal College of GPs here in the North and Doctors in Distress. So it was about highlighting some potential mental health issues, depression and suicide within doctors and healthcare workers. So it was I actually thought it was a very poignant event, and I mean, it certainly was very informative from my point of view, just to hear, sometimes we all think about going to doctors to get problems solved, but we maybe don't, and maybe overlook just the nature of the impact of the work that doctors and other healthcare workers have on themselves. So it's important that we look after those who work within our health system as well. And then just lastly, no surprise to anybody, that I intend to raise the IT issues within the Southern Trust that have affected patients the last couple of days. So in consultation with the clerk, I have suggested that we invite the Southern Trust and the department here next week just to give us a briefing on what happened, answers. I mean, it seems a bit strange that the backup system was affected as well. It doesn't say much about the backup system. So we just need to know what happened and what solutions are being put in place, and the impact that it will have on patients, or that it has had on patients and patients moving forward in terms of operation and planned surgery. And then also from the department's point of view, because we obviously have more than one trust within the region. So I think it would be important to get an assessment from the department about the resilience of our IT systems right across the North. I mean, IT is very important. We need it to run our health system, but we need to ensure that it's working effectively and that there are adequate protections on there. So I think that's something that members of this committee will be interested in, and it's certainly something that the community at large will be interested in. So as I say, I spoke to the clerk. We're going to have that briefing next week. Right? Everybody happy with that? Okay, thank you. So just moving on then, draft minutes. Can I refer members to draft minutes of the meeting held on the 11th September? Are members content with the minutes as agreed? Okay, thank you. Any matters arising? Okay. Moving on then, item number 5. So we're having an oral briefing on Caleb's cause, NI. Can I refer members to the following papers? Tab 5, page 25 of the main pack, and tab 5, page 3 of our tabled papers. So I met with Caleb's cause, Alma, just there at lunchtime to discuss the ongoing issue. So we have an update from Alma, and Alma has submitted very helpfully a number of questions, which I'm sure members will use in terms of this presentation. So can I just welcome the following departmental officials: Nigel Chambers, Head of Learning Disability and Autism within the Department of Health; Ms. Tracey Sproule, Social Care Commissioning Lead for Children's Disability within the Department of Health; and Ms. Caroline McGonigle, Social Care Commissioning Lead for Learning Disability within the Department of Health. So you're all very welcome. I'm going to hand over to yourselves just to make a brief statement if you want, and then we'll go to questions.
Yes, I'll keep this brief. So, good afternoon, everybody, and thank you for the opportunity to brief the committee on our work in response to Caleb's cause, which includes our work on transitions, the transformation of adult learning disability services, and the continued delivery of the cross-departmental autism strategy for 23 to 28. Now, as I open, I would also like to take the opportunity to commend the efforts of the families involved in Caleb's cause, who have, through their tireless efforts for striving for a better world for their children, have ensured that SEND transitions have been considered across the entirety of the Northern Ireland Executive. Now, the Minister has met Alma on several occasions and remains supportive of the campaign and the need to deliver better outcomes for children with SEN as they enter adult services. And at an official level, we continue to engage directly with the campaign, but also families outside of it, to better understand the issues and challenges that families face as their children finish school, and to co-design a way forward. And at a human level, Caroline, Tracey and I, we're parents, and like all parents, we believe that our children could do anything. But when it comes to SEN and disability, there are barriers that are difficult to overcome. But what is clear is that no child should have a ceiling on their life or their aspirations that are created by our system of government, our legislation, our structures, or the way that we fund our services. Now, in terms of the context, the issues and challenges around transitions are well rehearsed at this stage and were clearly documented through the Bamford Review Equal Lives in 2005. And while today's discussion is focused on transition from school, a person with additional needs may need support to navigate transitions through several points of their life. Now, in 2005, the issues documented were around lacking interagency working and collaboration, absent continuity of care and support, which resulted in a cliff edge that families experienced, and often planning was left too late, which ultimately constrained the ability of public services to commission supports on a long-term basis. In 2025, those challenges remain valid today, and at the heart of this policy challenge are three stages that need to be addressed in parallel. In terms of planning, from early years services, schools, healthcare professionals and social care, we spend a considerable amount of time and activity with children with SEN from the day that they're born. And despite such clear sight of these children and accompanying large databases, we do have a system that continuously acts surprised when a child turns 4 and enters school, and turns 19 and enters the world of employment, education, or adult social care. We need to move from being a data-rich system to a data-informed system. In terms of process within health and social care, there is lacking standardisation on the process and criteria that's used to assess and transition children as they move into adult services. In addition, health and social care transitions tend to be considered through the narrow lens of social care, through daycare, through short breaks, and through transport. And while these are all important services for people with learning disabilities, greater consideration needs to be given to the physical and mental health care needs of this population, as well as improving connections with non-HSE services to ensure that the opportunities available at the end of adolescence are the same opportunities that we had when becoming adults. And the last component that needs to be addressed in parallel is around delivery. And while Caleb's Cause campaign focuses, a key part of it is around legislation, it is important to remind ourselves that effective transitions management is ultimately dependent on the availability of services within the adult sphere. And too often, transition options are limited by capacity in adult services. We fit people to our services. We do not fit services to the needs of our people. While we cannot legislate our way out of what is a clear demand capacity gap in adult services, the Minister has committed to exploring legislative change through the implementation of the Learning Disability Service Model. Now, I'll very quickly go through some of the work that we've been doing since I last briefed you on this matter. In terms of the work undertaken by the Department for Economy, the Department and Minister welcomes this work and is supportive of a whole government approach to address the issue of SEND transitions, and agreeing that cross-departmental strategy could be an effective vehicle to pull together significant pieces of work across health, education, communities, economy and infrastructure. In June, the FE proposed that the disability strategy led by DFC might be the right vehicle for this, and I suppose it's important to reflect that SEN is more than disability, and we may need to think of a different vehicle to move that forward. All departments, but certainly Health, agree with Minister Archibald's statement around the need for multi-year funding. I talked about the challenges around planning, so even with good sight of the children that are coming through the system, without that being accompanied by multi-year investment to commission services on a long-term basis, we will see the train coming to us, but we won't be able to move. One area where the department remains concerned in its engagement with the FA is around the recommendation that day opportunities should be expanded for those that do not meet the thresholds of learning disability. Now, we do concede there remains actually a significant gap for autistic children as they enter adult services, as there is generally not an adult autism service waiting for them. And as well as that, there are children that would have IQs that are just above the thresholds for learning disability. Both parts of the population are being looked at through our service model and our autism strategy, because we do recognise that borderline cases and those with autism, a small cohort of them, will present with comparable levels of vulnerability to those who are within the learning disability services. In terms of next steps, Health is part of a joint transformation bid of, keep me right, £6.5 million with DFE and other departmental partners. This sets out for Health two key pieces of work around our transitions protocol to pilot across trusts and the expansion of day opportunities. In terms of our transitions protocol, this has been developed to standardise the process across health and social care trusts as they move from children with disability services to adult learning disability services. From memory, this was shared with you back in February. Where we're at the moment is actually moving out to wider engagement with children, young people and families from the 2nd of October to test what's in the protocol, along with an easy read to improve accessibility. The next phase of this work is a localised pilot, which has been included within the transformation bid. And while the quantum of funding required for this is not significant, this is within the context of significant financial challenge within the Department of Health in terms of maintaining service provision and pay parity. As a cost-neutral exercise, as part of the protocol, a transitions database has been developed and rolled out from the 1st of April across all trusts to regionally collect baseline information about the number of children known to services to assess project the future need for adult social care over a 5-year period. It would also be used as a basis then to share information across education, housing, supported employment and further education to enable them to better project demand. The second component of the transformation bid is around expansion of day opportunities, and this is by creating additionality within buildings-based daycare. In terms of adult learning disability services, we predominantly rely on buildings-based daycare, accounting for just shy of £60 million per annum. This would create additionality in that service to then enable people to transition into community-based day opportunities should their assessed need and choices allow that. In terms then of those pieces of work, they are both aligned to the department's draft learning disability service model, which was published by the Minister in mid-August for public consultation until the end of November. The service model sets out the department's vision, outcomes, plans and actions to produce a regionally consistent learning disability service across our 5 trusts and to recalibrate services to deliver better outcomes for people supported. There's a clear vision set out within the model in terms of transitions, as well as actions that will be progressed over a 3-year period. I would like to take this opportunity to encourage you to engage with the consultation where possible, and we are running a series of roadshows across all 5 trusts, as well as an online webinar, and we will be engaging directly with people supported in statutory and non-statutory services. In parallel with this work then, my team is also developing a delivery plan for the remaining 3 years of the autism strategy, which is due to be published this calendar year, and that will set out firmer actions and measurable targets with much greater clarity on what will be there for children with autism as they transition into adult services. Lastly, and I'm due to conclude, you'll be happy to know, the department remains heavily engaged with education in terms of SEN reform and the delivery of their transformation projects. Officials are embedded in new governance structures which have been designed to be more transparent, inclusive and adaptable to ensure that students, parents, educators, professionals and policymakers are actively involved in shaping and monitoring the reform programme. So in conclusion, there continues to be significant challenges faced by children and families as they finish life within special school or mainstream school in terms of transition. And Caleb's Cause have worked tirelessly to shine a light on what is a long-standing and truly cross-cutting policy challenge across government. The Department, as I say, welcomes the work that is being progressed by DFE and is now involved actively in the next steps in terms of progressing those recommendations, including a joint transformation bid. And I'm hopeful today that the evidence that we provide the committee provides you and the families with the assurance that we know what the issues are, that we are working across government and frontline services to design a way forward, and that we have a portfolio of work already in flight that will seek to make improvements to people's lives. Thank you.
Nigel, thank you very much for that. So, the committee had an informal meeting with Alma and Caleb's Cause just prior to this. So, I mean, this is a very emotional issue, and I mean, we obviously don't want to get caught up in the emotion. We want to find solutions to it. But I got the sense from that, having maybe engaged over a longer period of time, that certainly the families of children and families with children and young adults with special educational needs are becoming very despondent in terms of solutions, because they see in their cases very little happening. So, I mean, there was there was movement from within the Department for the Economy, but it wasn't really dealing with children with complex needs. I mean, from the meeting previously, we're told that families, they're very frustrated, they're under pressure, there's depression, there's stress, and in some cases, some of these families, some of the members are suicidal, for lack of a better word. So, I mean, that is a scenario where, as a politician, I become despondent, because this is an issue, you're quite right, Alma, Caleb's Cause has shone a very bright light, and the families from the Spotlight programme have shone a very bright light on this, but nothing really seems, certainly in the short term, to have changed. So I mean, you spoke very well, very eloquently. I mean, I don't for one second doubt any of the three of you aren't working as hard as you can. But in terms of actual practical differences from last year or 2 years ago to today, these families are seeing little or nothing changed. So, I mean, in simple terms, could you maybe explain to us what has changed or what is likely to change in the short term from the health department? Because in my view, complex needs is certainly a health matter. Now, we can talk about cross-government work, and there's a criticism that hasn't been as good as it should be. Perhaps that will change, but certainly from health's point of view, children with complex needs, what is likely to happen in the short term to help these families?
Well, probably a contextual point that will help with that. So there's approximately 70,000 children with SEM. Nearly 30,000 of those are statemented. Okay. Known to Health and Social Care Trusts, we work with 5,600 children with disabilities that are assessed by social work teams. And that would be across our 5 trusts. About 50% of those children will be autistic, around 40% will have learning disabilities. So you can see there that we are not working with the entirety of the SEM population in terms of our social care service, but that population is the population that is likely to need continued support in terms of adult services. Now, for children with learning disabilities, there is an established programme of care where they will transition to, which is adult learning disability services. That provides a level of certainty as to where children will be going, but there is recognition, and that is why I suppose what is set out within the service model, that even with that programme of care, even with children's disability and adult learning disability being in the same trust, we can clearly see that there are times when children are not transitioned well. Now, keep me right, there's around 250 children due to be transitioned to adult services in the next year. There'll be a number of those children that will be supported well, and they'll be supported well to transition because They will not present with very complex needs. There will be capacity in daycare, and the assessment of need will likely match the expectations of the person supported and families. So I suppose not to do a disservice to our health and social care system. They do work tirelessly to try and transition families and children well. But we do concede then, you can see clear examples where there's missed opportunities. So people at times will get transitioned into daycare when there is potential for community-based day opportunities, potential to do something that is more aligned to their interests, that is delivered with children and young people their own age, that is closer to home, and provides a greater platform then for them to actually develop some sort of independence and confidence throughout their life. So we can see that as a missed opportunity. And then certainly we can see in a number of cases, which I couldn't quantify, children and their families being let down quite badly throughout transitions, that even at age 20 and 21, you can still see no certainty in terms of the package that should be provided to meet their needs. So getting to your question, what can be done in the short term? The short term is what's going on now, which is the Learning Disability Service model. It sets out what needs to be done. It sets out what the service should be.
And what should the service be?
What should the service be? I'll take you through it very briefly. Okay. Based on our engagement with families, based on a wealth of evidence and nice guidelines around this, the way forward for transitions is very clear. Families want greater access to information that's clear and easy to understand. So what is the process when my child becomes an adult? Who do I go to? What services are available in my area? That lack of knowledge adds to the anxiety of the person supported and their families. It's about shifting away from just thinking about daycare to thinking about a person's holistic needs. And this is where thinking about their diabetes, their epilepsy, their mental or health or behavioural issues needs to be looked at in the round. Otherwise, you have a system that gets quite risk averse and limits people in terms of their transitions options because it's safer. It's safer to move someone to daycare because of their epilepsy and diabetes, because you have nursing presence there and you can keep an eye on them. But that might not be what they want. They're being limited by their healthcare needs. So it's shifting from that social care lens to a healthcare lens. It's about starting planning early. And it's set out clearly within our protocol that it is considered appropriate for, we'll focus on complex, from the age 14. Certainly not waiting until 18 or 19, but starting from 14, because those with very complex needs will most likely have a residential need. They most likely will require something creative and innovative around their day activity space. And they may require personal and one-to-one care through a large part of their life. So that needs to be planned for from 14, not left last minute. It's about looking at a person through their strengths and not just their needs. It's looking at them through the true lens of person-centred care and choice and control. It's not simply looking at your cognition and your social care needs. It's about what you want to do, what you're interested in. Because if you're doing things that you're interested in with people that you want to do, you're going to have better outcomes. And within that then, we are establishing, and this is through the pilot, but it's committed to within the model, the need then to build in transition link workers that would sit between children's services and adult services. So it's to bridge the gap between what can appear at a trust level to be two different organisations. So that's enabling people, it's giving them the single point of contact. It's answering all those questions I've just went through, like who do I go to? How do we navigate this? What's available? That's what's set out in the service model. It's going out. So this is a meaningful consultation on the service model. If we're going the wrong way on this, please tell us.
So, I mean, obviously, I want to bring on all the other members as well. So, Caleb's cause want changes underpinned by legislation. They think that is the only way to guarantee that this thing moving forward. So, you have said the health minister is open to the idea. When will we know? Is he pursuing legislation and what that legislation will include?
So I'm limited by what my minister has stated in the ministerial forward for the service model. There is a commitment there that we will explore legislative change if it aids the implementation of the service model. I think I've briefed this committee before. There is a lot of work across government in the space of transitions, and where legislation potentially could add value is joining up the dots. Because I think a lot of people are working hard, as you've noted, but people aren't feeling the change on the ground.
I just want to leave with this point, because I mean, all of these families want to do the best for their children, and I mean, they, and certainly I see it, the role of government to support them to do the best for their children, and we just aren't there, but we need to get there. I mean, at the end of the meeting, Alma said, we want to keep our children and young people at home, please help us. So, I mean, I certainly see that as the role of politicians. I certainly see it as the role of officials within the department. But, I mean, I think to this point we probably have not lived up to the expectation of these families, and we really need to get to there very quickly.
Certainly within health and social care trusts, in terms of complex needs, trusts and the department play a significant role, in the sense that we have a learning disability service. It equates to £500 million a year, and there is recognition that it's not delivering the outcomes that it should, and that very much is the rationale for us to put out the service model and say we need to do things differently. And it is the rationale to put it to families and people supported by our services to say, look, are we going in the right direction on this? So,
We'll let all
thank
members
you.
in here. Diane?
Thank you, Chair, and thank you for the presentation. Like the Chair, I do think that there's a lot of work, but there's as yet not a lot of outcome, practical outcome for people. Things that people can say, my life has improved. And I think that that is regrettable, because I think the situation is quite grave and quite urgent. And while I get that government has processes and consultations, and I get all that, I do get that, honestly, it doesn't improve that life prospects for young people, and it doesn't improve the position of parents at the moment. So I suppose that's, having said that, there's things that I think could be done, but and could be done easy. They're not, really difficult things to do. But anyway, I do happen to be privately of the opinion, and I'm saying it out loud here, that legislation is the way forward in this. I do think that we do need something that compels government to offer provision for young people post-19. And I'll say this, and I'll say it because of a very dear friend whose son had very complex needs, and went from having a very full life in school, from picked up after 8 in the morning, back home at 4:30, back to school 2 nights a week for youth club or whatever, had a very full life, to 2 mornings a week in a daycare centre with people who could hardly talk to him. And that's the reality for too many young people. And it's the reality, well, I suppose maybe even some of those young people are quite lucky, because I think some young people with very complex needs are at home, simply because there's nothing to help them. So I set that out as context. It's just a personal issue that and it's why I really, really believe that this is something that needs to be moved forward. And ultimately, in the end, it will cost the state more. Mm-hmm. If we don't. So we're going to, because these young people will have to become looked after, and their families will be broken. So a couple of things that I kind of want to know. What will be the scope of the pilot that you're hoping to introduce? Have you any sense of where it'll be introduced? What will be the terms around the pilot? And what do you think we'll learn from that pilot process that you're talking about introducing?
In respect of the...
Yeah, just a quick... we can provide a quick overview of the pilot, and I see also no reason we can provide you the detail in writing as well as to what the pilot sets out. So
Yes, so the pilot, what we would be looking to do is, within one trust area, look at how, I suppose, our understanding of transitions, and what people have said to us is that 18 becomes a cliff edge, and there's no one person to bridge that gap for families or for young people. So the pilot would look at establishing a team who would work from young people from the age of 14 up until 21, so they could be the point of contact. They will support that young person through their social care journey, but also what we would like to do is make those links with other, I suppose, issues that are going on around education, what's going to happen next, where they're going, and start to plan that earlier. So there's consistency in that, so that children's services don't work with a young person up until 18 and say, right, over to you adults now. Do you know, and myself and Caroline have worked, I suppose, very closely in making sure that there's coordination between adult and children's services within this protocol, and that children's services aren't off developing one protocol and adults are developing another protocol. We're doing this jointly, and we have worked with all the Trust's children's and adults teams to say, look, what do we think? How will we make this better? We've listened to what parents have said historically, and nothing really has changed for parents in respect to transitions. They're still saying 18 is a big, huge shock for them and for their children, and actually communicating what's going to happen, having someone there that they can talk to and having a plan is the things that will really make a difference for them. And that's why I suppose one of the first steps is, one, the database, so that we have a good understanding of the population need, but two, the pilot that will enable us to see, is this the right way to work? You know, bridging that gap, testing it out, and then being able to upscale that is what we would like to be able to do.
You had an additional question about, look, have we got a trust in mind at this stage?
We are working with you'd mentioned the transformation bit earlier on, and we're obviously hoping that that'll be successful. We want to work in partnership, you know, with DFE in terms of opportunities, you know, maybe skills-based apprenticeship, etc., and look in terms of the daycare. So we will select a place-based approach. The finer detail of that will be worked out. But what I do want to say is we have engaged with all trusts. They are very willing to make a difference. I want to pick up on chairs and committee members' point earlier on, like what are we doing in this space? And legislation was talked about, but we really felt that we needed to make a difference immediately. Something now, picking up on what you have said. So it will be incremental, but the changes that we have made is the transitions database. So now with that, each trust is putting on children at age 18, with the focus being on start and transition planning from age 14. That is really important, particularly if a child has complex needs. But we see 16 as a really pivotal age, because at that point, parents, the young people, should have a plan, a trajectory in place as to what is going to happen. It's too late to leave it to 17 to 18, and unfortunately, as noted earlier on, with pressures in children's services and with pressures in adult services, sometimes that happens, and that's not okay if you're the young person or you're the family involved in that situation. So within the database, we also have a bit of a trigger. When someone is moving into 17, you know, we really want to hone in on that sort of discussion and early planning. So trusts are really, really committed to that. We want to go out to the parents and carers and say, we've listened to you, we think we have captured what you want us to do, is this what you want us to do? And then we would like to test the protocol, but it'll work best if we test it in an area. For example, we pick a particular trust and look at what can be done in terms of those apprenticeships, etc., test our process. And then also the information that it gives us will help us with population planning at a later point, because Nigel, the key for us in adult services, we should know at the minute they're focusing on trust land, populating the data, but within about 6 months' time we should be able to know, for example, more ready information about numbers that might need daycare, numbers that might need day opportunity moving forward. So that's the sort of information that will really help us, and housing. Because if someone is in a placement, sometimes if they need a bespoke arrangement, that can take a bit of time. So it will enable us to work with, you know, other organisations and agencies across the system. That's our hope. It won't happen immediately, but we are very committed to making this work.
And Troy, I just want to ask a question there, because I'm a bit confused, Caroline. Not confused, I'm just a bit worried. You know, you're talking about a pilot in an area. I mean, when I hear that, all I'm hearing is it's going to be a delay for families in all these other areas outside the pilot. So, I mean, what timeframes are we talking about here?
So if the pilot falls within the transformation bid, I believe funding, if successful, will be due to be released from the centre at the beginning of next year. We're talking January of next year. Should we be unsuccessful, I think our approach would have to change in terms of rolling out this protocol and these transition link workers, in that the service model consultation is due to conclude at the end of November. We'll be undertaking analysis of findings, I would say, throughout December and January. But the intention then would be to go to the Minister in terms of a cost and implementation plan and decision within the financial year. So if the transformation bid doesn't allow us to test this through a localised pilot approach, we will just need to proceed based on the evidence, based on the feedback from the consultation and the direct engagement with families on the protocol, to just proceed with a regional rollout.
Right,
Do you have a figure for what the bid to the transformation fund would be?
It's 6.5 million, largely between DFE and the Department of Health. We account for 50%, just over.
3.6.
Yeah.
3.6 million.
Sorry, 3.6 million.
What is it?
So the health accounts for 3.6 million of a 6.5.
7.5.
This is why they don't let me near numbers. And that will be delivered over a 3-year period if successful.
So does that mean that the pilot is going to be over? I'm sorry, confusing me as well now. Does that mean that the pilot is going to be over a 3-year period, and that's in one trust? Then we'll take the learning from the pilot and we'll try to apply it to other trusts. Meanwhile, those young people in the other trusts won't have nothing will have changed.
So the pilot,
have I picked that up right?
The transitions protocol pilot is the smaller part of the transformation bid, and it would be delivered over a much quicker time period. The largest part of the bid is the shift in community-based day opportunities, and that is across all 5 trusts. So that's adding additionality to daycare so that people could be supported to transition to day opportunities. So that overcomes the concern of one trust being ahead of others, and 2, that the significant time delay between pilot and implementation. So I say if the transformation bid is successful, that will be commencing within the financial year.
So of the young people that you have and that you know will transition, I think you said 250 young people will transition to adult services in the next year. Do you know how many of those have complex needs? How many will go into like a further education college, into some sort of course, or how many will need a package that enables them to function more independently? Do you have an idea how that 250 breaks down?
So at present, the data systems that we have in place don't allow us to get down to that level of granularity.
And how can you plan if you don't know what the need is?
And that's why the database was established separate to that. So prior to that database being established, and it's currently being populated, I'm able to come in front of you and say, well, there is X number of children known to the children's disability teams. I'm able to give you the split between learning disability and autism because that's how they've been coded. But to get to the heart of the question you're asking, which is, well, how many of those children would be considered complex or very complex that would require something very bespoke and specific as they age into adult services? That is a current data gap in terms of what's within trusts centralised with the department. So that's where the database is trying to fill that gap. Because then we get a much greater understanding of children from when they're 14. We understand the presentation of need. We understand what's as likely to be a residential or supported living need. And we understand the potential. When we talk about the very complex in a day activity space, we are conscious that they will most likely require higher levels of staffing. And as they transition potentially into adult daycare, that higher level of staffing, that lacking compatibility with sometimes other people on site, that is one of the key challenges as to why daycare capacity has been reducing over the past number of years. So, you take a site that was maybe supporting 30 people, it's maybe supporting 20 today because they are supporting people with a higher level of complexity that do need to be separated from others within the site and require additional staff. That is the challenge we need to get ahead of in terms of day activity. Part of it comes down to planning, part of it's down to the database.
Just finally, how have your services recovered from the COVID period? Are they back to pre-COVID levels? Are they still languishing? I thought in some trusts they were, and particularly residential and respite services for young people with very complex needs?
So the short of it is that they would not be at the capacity they were pre-pandemic, but for different reasons. So I just started in the department during the pandemic, and one of the central challenges during that year, or 2 years of the pandemic and remobilisation, is that infection prevention and control guidelines had limited capacity. So social distancing, I suppose isolation, even testing, that limited a daycare site down to 50 or 30%. It limited buses to like a few people on them to kind of meet these requirements. That has largely been left in the rearview mirror, if not entirely left in the rearview mirror. What we have now within daycare, particularly daycare, is an increasing complexity of individuals coming into the service from children's services that, as I say, require higher levels of staffing and can be less compatible with other people supported on site. So the day centre is fully open 5 days a week like it should be, but it's not supporting the number of people. Part of that challenge, as I say, is around complexity. Part of it's around ensuring the workforce is there to support them. And for some of the daycare sites, some of the environments are quite dated, where if you do have somebody with complex needs, you can struggle to kind of flex the environment, to kind of segregate the environment to support people without reducing capacity. So if you think some of those really old daycare sites that haven't had capital investment, maybe 20 years, they really struggle with that current day challenge. Okay.
Thank you. Linda?
Thank you, Chair, and thank you to Deanne for some of her questions, because she's actually covered some of my stuff. I suppose I know you've covered the daycare element. It's just a comment more than a question at this point, because we're speaking specifically around the Caleb's Cause legislation today rather than respite and residential. But I can tell you in the Southern Trust it hasn't recovered in relation to respite, certainly services for families, and a lot of that is to do with the fact that there aren't adequate or appropriate residential services for young people moving from children into adults, and therefore they are taking up space. And that is not the children's fault nor their families, that's just poor planning. And we really do need to address that. I'll pick it up with you at a different point, Nigel, because I understand that's not what you're here for today. So just on the issue that we are here to discuss today, I'm going to give an example. So just, I suppose, to highlight for other members and for the wider public out there of something that I think could be easily overcome and why we can't, and I want to get an understanding as to why we can't overcome it. So I had two families who came to me, both children with quite complex physical disabilities and some learning disabilities. So they have significant health and care needs. But both of them were accepted onto a course at Southwest College. First of all, they were accepted, this isn't your doing, they were accepted into a site that doesn't have the facilities for them, but is actually running the course, rather than the site that should have been running the course that does have facilities for people with disabilities. So that's one issue that has been overcome with Southwest College. But now their health and care needs cannot be met. Now, the college were told before the summer, the social worker was told, everybody was made aware that this was going to be an issue. And here we are sitting almost at the end of September with two young people who have a course that they've been accepted onto, who are very capable of doing the course, who can't have their health and social care needs met at this time within the Southwest College, within the setting. So that's a real clear example where there is not cooperation, where we're not working together, but we're, honest to God, I think we easily could. And I just want to get an understanding of the transformation bit that you're talking about that has been put in. Is that going to overcome that kind of issue? And will we see that having an impact very, very quickly, if that's the case? That's my first question. Do you want to answer that one, Nigel?
Yes, that would be helpful, if you're okay with that. Well, there's probably two components to it. So one, that is very much an issue and challenge that we were cognizant of, that a person's social care or medical needs can really close doors for them at the point of transitions. I mentioned diabetes and epilepsy, which for the general population don't close doors for lots of things, but when you do have additional needs on top of that, the system can become very risk averse. So I suppose in terms of the service model and the protocol and what it sets out, that is the key as to why we need to shift away from the narrow lens of thinking about transitions in social care only. We need to think beyond just day services, respite and transport. While very important, we need to think about how do we support and manage risk about a person's underlying medical or mental health needs as well, to ensure that those things do not close doors for them. The other component, and this is something that we have considered within the service model and we need to give greater consideration to, conscious there is another piece with our nursing and social work colleagues around the use of self-directed support in terms of personal care and delegated healthcare tasks. So it's a potential vehicle to enabling people to commission a support that enables them to access a service outside of health and social care. So I suppose the short of it is, it's an issue that we're aware of. It's within the service model and the protocol as a set of considerations that need to be navigated. But I suppose in terms of the families that you've raised, it'll take time before we can change the system so they can see the change in outputs.
I think that one could be, I know you're saying about self-directed payments. I'm going to pick that up at a later stage as well with the department and with the minister. I think that system needs to change. We're making parents who already have, and not just parents, but families who already have the pressure of the world on their shoulders, have so many challenges, and we're telling them, become an employer, be the risk taker. We'll not be that body. We'll not do that for you. So I think if we can, and I'd like to understand, is there any work going on within the department to look at how you change the self-directed payment? I'm not saying...
Yeah, I can give you a very quick overview. Actually, yes, there is. So for the past year, self-directed support, on one end is, yes, it's direct payments, and for some families that works, but for a lot of families, you become the employer, you have the governance, you hold the risk, and that burden on top of carrying responsibilities on top of everything else within life, that isn't a meaningful offer. As part of the self-directed support continuum, there was the commitment 10 years ago to develop managed budgets. Now today, managed budgets are few and far between, and essentially what a managed budget is that I assign you a budget, you have X number of pounds to commission your care, but as a health and social care trust, I carry the headache. I carry the risk as being the employer. I carry the governance, I carry the administration, but you tell me what it's spent on. So for the past year, we've been working with the Association for Real Change and Impact to undertake an exploratory exercise. So this was funded by Impact for the past year to explore what have been why are managed budgets not a reality? And for the trusts that have been doing it to a small degree, what is stopping the other trusts from doing that? So that has, at this stage, produced a series of recommendations for what needs to be done to expand managed budgets to a much greater degree. The next phase of that work is, don't sigh at me, but it is another pilot, but we have identified pilots across the 5 trusts. That extends beyond, that it's mainly learning disability, but within one trust as well, it's also working with children that are autistic, because there's a different set of, I suppose, considerations to be navigated. So we are trying to move the commitments around managed budgets further, because it gives people a lot greater choice and control to commission services that are personal to them and work around their own family considerations in healthcare and social care needs.
Okay, Nigel, I normally am the person who's shouting about pilots, okay, and giving out about them, but I'm okay with pilots if we have a plan of how they're going to be rolled out if they work. So if you can, and I'm not going to ask you to do this in the meeting today, but if you can furnish us with the recommendations and then what the pilot looks like and the plans. So as much as you can give me, I understand that some of the plans will be based on the outcome of the pilot. So I understand that. So if we can just get that information in written form, even to the committee members, I would really, really appreciate that, just to get an understanding, because that's one of the biggest challenges that I meet with families. And if we had something like that these 2 families could have been told, last April, May, when they knew their child was going to hopefully be going to Southwest College, and we're so excited that this was an opportunity that their child was going to have, and it's just been turned into an absolute mess for them and a nightmare for those young people, because they're very clued in, young people. And, you know, I'm sure you'll have had this before, but I've had young people saying to me, what is the point of me? Like, that's, you know, that is, and the chair's right, you know, this can be very emotive, but it is emotive for a reason. We are talking about human beings, very valuable members of our society, and we're not showing them that value. And every single one of us has a responsibility to change that. So I think that if we can work together to try and do that. So I suppose for me, that is one of the things I definitely want to get an understanding of, is how we can do that better, putting everything in place at the right time for these families and children. So again, I think you already said, so just in terms of the transformation and the pilot, I think you said you're gonna give us the details of it. I know you did outline some of the detail of it, but we can get the details of that in written form, because again, that may answer some of my questions, and I would just like the opportunity then to come back. I suppose a bit like Deanne, you know, I think if legislation can help here and can, you know, put a framework around this that ensures that every child is looked after and every child has a good, fulfilled life, because this goes much wider than health, goes much wider than DFE. You know, this is about housing, it's about community, it's about support. But in those pilots, I would like to see greater cooperation, particularly between health and voluntary and community sector, because we often talk about voluntary and community as something that's funded by health. Let's work together. There's definitely more that can be done in the sphere of working really, really closely together. Everybody would benefit from that. You know, the people in the voluntary community sector will benefit, the people in our health service will benefit, but most importantly, those young people and their families will benefit. So I suppose when we get the details of those pilots, we'll see more in relation to that. But legislation is what legislation is. It takes time, and I don't want us to wait. So I'm glad to hear that there's work happening. We're not waiting on legislation, but that doesn't mean that we don't do it. You know, all of these things can be done. All of these things can be done in tandem. So I appreciate the presentation today, and I look forward to the other information coming, and we may then need to have another conversation. And I suppose, as I say, included in all of this is, you know, every single element. So the respite, the transport, you know, where it may be required residential services. So there's a lot of work on this, but I know you do have a focus on it, Nigel, and I know that you have done a lot of work in this space, and I've been meeting with you regularly over the last couple of years, maybe the last 3 or 4 years. I can't even remember. Years are rolling into each other. But I do appreciate that you do communicate with us and do meet at every time I've requested. You know, you've always met with me and with other people who have asked you to meet with. So, but we just need to work together to deliver this, is, I suppose, my point. Thank you, Chair. Thank you.
Thank you. Danny?
Thank you, Chair, and thank you for that presentation. I would first just want to declare an interest as the chair of the All-Party Group on Learning Disability, and as such I've met lots of groups, including Alma, Caleb's and our charity, and Nigel many times as well, and I always benefit from those engagements, and certainly I don't doubt any of the commitment from the department working on this. I have a couple of questions. So my first one just is around the bid, the transformation bid. Forgive me if I've got this wrong, but there's a £7.6 million bid in a minute for the pilot programme and for an expansion of day opportunities. Is that correct?
Mm-hmm. Yeah, so it's the pilot of the protocol, and it is the largest part of the funding in terms of health is for the expansion of day opportunities by, as a first step, creating additionality within daycare, and then using that additionality to work with people so they can transition to community-based day opportunities, which are predominantly, just picking up on Linda's concluding point, are predominantly delivered by the voluntary and community sector.
Yeah. And certainly I'm very aware of a lot of those organisations and the fantastic work that they do. If this bit isn't successful, there's no funds then for that expansion, is that correct?
In terms of the transformation bid and the pilot, it will require a change of approach. So it will then be progressed through the delivery of the learning disability service model. Now, Learning Disability Service Model consultation will run until the end of November. We would be hopeful that we can take a costed implementation plan to the Minister within the financial year to allow time for analysis and costings. So that is where decisions will need to be taken about additional funding. However, the service model is working across a programme of care that does account for at least £500 million of services. So part of this is about reconfiguration. Now, that does not put it entirely on the trust to say, look, you need to use your money differently. There is money needed from the centre to make that possible. But we spend £60 million on buildings-based daycare, and we spend about £10 million on community-based day opportunities. We need to shift the pendulum a bit more towards community-based day opportunities, because that is the way that we provide greater choice and control for people in terms of activities that they want to do within their communities. And it provides also greater opportunities in terms of evenings and weekends as well. But that will also involve a recalibration of where we're spending money on the sharp end of learning disability services. And you and I have had conversations separately about high cost placements. We currently spend 20% of our funding in learning disability on high cost placements. We need to think about how we normalise care there so that we can spend it to actually benefit the largest part of the population who are in our service.
Yeah, and thank you for that. It does appear to me in a very general way, and I know it's something that Alma has championed for quite a long time, that the statement of care just seems to expire at 19 here in Northern Ireland. And, you know, that doesn't seem to deliver any support for anybody. Given that we have multiple departments all looking at this now, is there any consensus on where the responsibility actually lies ultimately?
Certainly for those with learning disabilities who will likely, one, they will have assessed learning disability, and two, they will likely cross a threshold in terms of social work. The responsibility primarily lies with health and social care in terms of meeting the health and social care needs of that population, which are predominantly delivered through our residential units, supported living, day services, respite, transport. But health and social care also need to play a role to enable those people supported within our services to access further education, to access supported employment, and that is done through community-based day opportunities. So, I mean, one of the things set out in Equal Lives is that learning disability, that we need to shift the mindset that learning disability is a health problem. People with learning disabilities have health problems, but they have housing problems, education problems, benefits, etc., etc. Learning disability is everyone's problem. It's just that health and social care will have a significant role. In terms of the more general piece of who has responsibility for children with SEN post-19, it depends. I'm sorry. It's because it's such a diverse population, from very mild SEN to very complex disability and needs. And that is where it cuts across. And that's why I say transitions cuts across the entirety of government. We all have a role. At times, some have roles more than others.
It does strike me that that's part of the problem, that there are so many people, there's so many departments who have a role in this, and there's no real sort of coordination. And I think that's where, you know, people have been falling through the gaps. And I appreciate there's a lot of work that is ongoing here at the minute, and there are a lot of people who are well supported and doing well in day opportunities and in daycare, and I've visited lots of these organisations. But certainly disability is lifelong, and I think that the complex needs of these people are kind of not being catered for at the minute, particularly young people with who lack mental capacity. No problem. Thank you very much for that, Nigel. I'll take that away, and the answers to the other questions have been very insightful as well. So thank you.
Nuala?
Thank you very much for the presentation. I'm going to move on a little bit on a different angle. I was curious about some of the other questions, particularly around that transformation funding, because it is something that we hear from many people who present to us as a way to kind of capitalise on changing the services for good. And some of my questions are focused around individuals, and they do come from a lot of family members. And it's around the kind of recognising individual needs of the young person, and at what point, if you can answer us, at what point will that young person be, or are they always assessed for what level of support that they require?
So are you referring to those who would be known in our Children's Disability Service when they would be assessed?
Yes.
Well, what's set out in terms of NICE guidelines and what's set out through our service model and our protocol is that planning may need to start as early as 14. There are individuals where that planning could be left perhaps until 16, but certainly you wouldn't want to be getting anywhere near 17 or 18, because that is really limiting the capacity of adult services to project demand and to ensure placements are ready. And that is, that is a central challenge, and that you're hearing more and more from your constituents that the offer in terms of day services, whether it's community-based day opportunities or daycare, is a fraction of maybe what it would have been 10 to 15 years ago. You hear a lot of shift from 5-day packages of support. And actually, Dan, you mentioned about the shift from education, where somebody was in for quite a large part of the day with people their age, with a curriculum and activities that were really building their independence and confidence, to then quite a sharp drop, not in terms not just of the volume of the service, but actually the nature of the activities, and people potentially regress. And certainly when we speak to special school principals, that's what they say. They get really depressed when they bump into some of their pupils and see the steps back because of the shift to a service that is at times can be quite limited. So that is the need for having to assess people as well. The key part of why we need to start assessing people much earlier while they're within the Children's Disability Service, to ensure that the service is actually waiting for them is aligned to their needs, so that your transitions aren't being limited to what we have. Your transitions are reflective about what you need. Yeah.
So how do we bridge the gap between this great transformation and the now? So if my child is assessed needs one-to-one support to access a day centre, but they aren't given that one-to-one support, therefore they can't go to the day centre, where does that child currently, adult, age 19, where do they go? What's available?
Keep me right. Typically, those with one-to-one support needs would go into daycare, but the doors would close the door for community-based day opportunities. It's an issue that we're navigating in the sense that with those who have learning disabilities and co-occurring autism, the complexity of their need is shutting down their potential choices and options when they become an adult, because they require one-to-one support, so they inevitably get shifted to daycare.
And do all of them? So if they need the one-to-one support, to access that day provision services, do they all get it if they need that one-to-one support, and then the list kind of is longer for the ones who don't need it, or is the shift in responsibility and sometimes put on parents? So does everyone who need a one-to-one, I'm just trying to understand the situation, does everyone who need a one-to-one support worker get one currently?
It'd be aligned and assessed need. I suppose that would be dependent on the trust perspective, if you know what I mean. They would conduct the assessments and make that determination, but services should always be provided in accordance with assessed need. Okay. So I think what Nigel's trying to say, for someone with that high level of support, probably daycare is seen to be the best option in terms of meeting their needs. And from a service perspective, the person themselves may not want that. They may want to avail of day opportunities, and that should be or could be considered by the trust.
Sorry to interrupt, but can you just outline the difference?
Yeah, right. So daycare is a largely statutory service. It's regulated as buildings-based daycare. And this is where you're hearing probably from your constituents about limited capacity within daycare, limited activities, and then something this committee's raised a few times, mixing of people across a wide age continuum. My 18-year-olds going in with guys who are in their 60s and 70s. So that's daycare. It's
day opportunities.
Day opportunities has been grown really in the past 10 to 15 years. As a consequence of Bamford. It's primarily delivered by the voluntary community sector. Okay, it's much more diverse activities. It's not necessarily delivered during the 9 to 3 or the 9 to 5. It's delivered as and when people want. It has closer links to further education, supported employment, volunteering, social farming. So
social farming, performing arts, those types of programmes like what you're talking about, that are maybe more individual based, whereas in a day centre they will do that, but it will be within that building space environment and group focus.
But can there be young people who require one-to-one support and day opportunities are better placed for them to access? I mean, why would they be assessed for having one-to-one support but needing to be in a day centre versus one-to-one support and getting day opportunities?
And
where do the obligations change from statutory to...
Yeah, and this is the challenge. Typically, if somebody is assessed as needing a one-to-one support, they will be placed within daycare because we are best equipped to meet those needs within a regulated daycare setting. And that might not be aligned to what they want to do or the aspirations that their parents have for them as well. And it's something as part of that shift that we need to achieve through the service model and the pilot. We need to ensure that a person's wider health and social care needs, such as co-occurring autism or medical needs or behavioural and mental health needs, don't close doors for them. And it's trying to shift away from being risk averse, because daycare is safer in the sense that it's a controlled environment. We can put more staff on people, but in terms of their hope, their aspirations and their hopes and what they want to do, it's not going to be able to meet all those things. So.
Yeah, I'm slightly confused in terms of where the statutory obligations stop, because self-directed support then becomes our direct payments. What do we expect parents to use direct payments for then?
Okay, no, I get you now. So and whether we use buildings-based daycare, community-based day opportunities, or self-directed support, that is in response to a statutory duty. Okay, so as people shift into an adult service in terms of learning disability, and they will be assessed under the Chronically Sick and Disabled Persons Act 1978, which sets out very clear expectations of the Department of Health and the delegated health and social care system to provide A, B and C aligned to the assessed need that's typically undertaken by social work. So yes, somebody in day opportunities, we would still have a statutory responsibility to them. It creates the framework in terms of assessed need and delegation of responsibility to trusts.
And if we need more staff in order to facilitate young people being with their peers for day opportunities, and notwithstanding that we all know there's funding issues, but payment is being made for direct payment. There's payment being made at some point for something. So why can't we hire more people to actually facilitate those day opportunities?
And with financial context aside, that is why we need to recalibrate the programme of care. We need to, I suppose, the programme of care, as I say, costs £500 million. It's increased by about 36% in the past 5 years, but that 36% uplift to the service has not been equitable. It's been spent on the sharper parts of the service in terms of our crisis support, in terms of our high cost placement and supported living. It's been spent on our hospital discharges from our long-stay hospitals. It needs to be spent in the day activity space. It needs to be spent in respite. It needs to be spent in transport, because that is where you can see clear demand capacity gaps.
But some parents are paying. Some parents are using the money to pay it, to get it. I mean, most. Well, anecdotally, I obviously don't have the statistics in front of me, but it's very hard to find a support worker, yourself, and to get that. So there is money that exists, and and this isn't just for adult provision; it's for young, under 18s as well. Money does exist, because sometimes it's on the person who has parental responsibility to find the support needed to engage. So do you get what I'm saying? When that there is money there, because it is being passed from one bank to another for that person with parental responsibility or legal responsibility to find help for that young person. And I know the systems, I know things aren't simple as just simply hire more. But in the bridging gap between this total transformation, why can't we hire more support workers? Why can't we actually be able to do it, to get those day opportunities for people to be with their peers, for that bit of respite whilst we await this big change?
Present, and I can provide you further input, but the financial position within health prevents any further money being released from the centre presently. That is, even within that financial context, as I say, we will be costing the service model and approaching Minister for a decision on it in terms of implementation. But why can't we employ more people in terms of day ops, in terms of the support services around them? The challenge is financial, but equally we have to grow the workforce, and we do have to grow the voluntary and community sector. And look, we have to commend the voluntary community and the independent sector in terms of everything that they've done within community-based day opportunities. But simply throwing more money at the sector, the voluntary and community sector, will not produce a change overnight. So there's a responsibility on the department, across government, and within health and social care trusts to actually grow the ecosystem of community-based day opportunities. Because I think if we found over a few of the issues that we've discussed through this committee, more money sometimes is only part of it.
And I completely respect that. And we're maybe not going to get the answer today, but we are throwing money at parents or those with parental responsibility to find the support. So it's I imagine that there would be parents who'd say, take that money back and find it for me. I cannot do it. You know, we get this, and I have probably more experience with dealing with parents with children of learning disabilities, and it's the same. It's the same in both. But I suspect, you know, we're not going to be able to get an answer to that. But it's that bridging gap that I'm particularly focused on before the transformational piece actually takes place, because we know it will take a while, and we understand that it will take a while as well.
Look, it's an important question for us to take away with us today. I'm thinking, yes, we're out to consultation. Yes, we want to be shifting to implementation with the transformation bid. But yes, we will take that question away and think, is there anything more we can be doing today to start increasing capacity where it's needed?
So before bringing in Alan, so last week the committee was made aware that the Department for Finance is writing to all the departments in terms of kind of 5-year planning from a financial point of view. So we've asked for the Department of Health submission to that. In relation to this subject that we are discussing, what is it likely to say in terms of the financial implications or spend within the department over like a 5-year period in relation to trying to solve some of the problems that we're talking about here?
Well, we've in the past year we've undertaken an in-depth financial analysis of the Learning Disability Programme of Care. Alongside that then we've carried out an in-depth analysis of our high cost placements. So this was to get us a greater understanding of where money is being spent, and to help us begin to develop options of how we should be recalibrating the programme of care. As I said, look, this will need additional money. I'm naive, but I'm not that naive.
But no, and that's what I'm asking. I mean, because if we're talking about, I mean, we're saying that, I mean, we've heard Paul Given talking about SEN from an educational point of view. So, I mean, there's numbers that are increasing. So, I mean, when those children at 19, that's going to increase. So the numbers are going to continue to increase. So, I mean, essentially, I'm just asking in terms of the preparation within the department, looking forward, what it's likely to suggest.
Okay. Those exploratory pieces we've done around finance have helped us understand what we're spending money on today. Following the consultation of the service model, we will be undertaking a robust costings exercise to actually set out how much it will cost to shift this service. Part of this is the recommendations within the service model are cost neutral. Part of it will require recalibration of what we're spending money on, and that will take time. It will take time to shift money from the sharp end of the service to the end of the service that people see on a daily basis. But it will also require additional money from the centre as well, in terms of expanding some of the services that could just benefit from additional investment. You know, there's creative thinking, but when you have demand capacity gaps across a range of the services, like sometimes you just need to do more.
Okay, thank you.
All right.
Alan, interrupted Alan.
Thank you, Chair. Can you hear me okay?
Yep.
Yeah, thanks, Nigel and Tracey and Caroline. I appreciate there's no future in the past. I think the chair used at the very beginning there the term despondent, and I'm watching very closely there, and I see Alma behind you increasingly becoming despondent. And I suppose there's a very obvious question here that I wanted to ask amongst a couple of others. You talked, Nigel, about the Bamford Review back in 2005. There's obviously been a recognition over all those years, over decades now, of this cliff edge. It feels to me, and do you recognise this, that it is only as a result of the campaigns, the admirable campaigns from people like Alma White and others, that this painfully slow juggernaut is only starting to nudge forward now? And can I ask that very obvious question? Why is that? Why has it taken, campaigns, sustained campaigns from Alba and others to start to get to a place that potentially will bring some benefits. Is that an unfair comment? But
a question I really struggle with. I think you got me last time with a difficult question that was here. Why is it taking so long? And why is it taking a campaign? What I can say is the Department of Health and Health and Social Care have always been quite active in the space of transitions for a cohort of children with SEN. And there has been, while there's been limited progress across Northern Ireland on this issue, we can see over the time period since Equal Lives a seismic change in terms of how the service is being provided, shifting from what was an institutional hospital model to a community-based model. And that hasn't been a painless process. That's been a difficult process, and at times a chaotic and reactive process. What I would say, and what I put within my opening remarks, is that Caleb's cause has reminded all departments and across government that everybody has a role in terms of SEN transitions, and certainly from the perspective of health, that learning disability is not solely a health issue. It is an issue that cuts across the entirety of government as well. That has then produced, of course, action across government, and we are supportive in terms of what was published by DFE in June. And there is now, I suppose, a considerable amount of work that is now being progressed as a result of that. I think where you will remain cynical and concerned is how well that will be coordinated, and whether or not it will actually produce outcomes that impact people's lives, or will it just produce officials telling you that you're really busy and we're producing lots of paper. So,
Nigel, on the transformation piece, or transformation funding piece, if that is successful, forgive me for asking this, but will that transformation funding provide long-term benefits, or will it only provide those benefits over the period of that transformation funding? I think you made reference to 3 years.
Yeah, so the funding's spread out over 3 years. I can speak for the health component of it rather than the DFE piece. And certainly in terms of the pilot piece, in terms of the protocol, that will produce lasting benefits, and that will actually test whether or not the approach that we've built based on evidence and engagement with families is the right thing to do. It will ensure that whatever teething problems we identify can be ironed out across our 5 trusts. So it will produce a process and systems change. Now, the piece around day opportunities and providing that additionality within daycare to enable people to transition, its lasting impact will be sustained through the implementation of the Learning Disability Service Model. So it will need to be accompanied by the strategic work that the department is progressing and the implementation of the model that is currently out to consultation. Yeah, I'm keen to avoid a fixed term pot of funding that improves things for a few years, and then it's like that works really well, but we've got no money. We need to ensure that that sustainability is planned from the outset.
Yeah.
You said as well, Nigel, in your piece that the Minister will explore legislative change. And I noticed Alma's body language dramatically changed. As you can imagine, she doesn't want, and we don't want to see him exploring it. We want to see him committing to it. But anyway, thanks, Nigel.
Thank you.
Okay, Nigel, Tracey, Caroline, thank you very much. That was a long session, but we appreciate you giving us your time, and no doubt this issue isn't going away, so we'll be back here at some point in the future. Thanks very much.
We'll see you in 3 weeks, actually. Thank you.
Okay, members, just Alma had submitted a number of range of questions. So some of them were picked up during that, some of them weren't. I am going to suggest that we forward those on to the department and try and get written answers to them as well, if everybody's content.
Yeah.
Okay, thank you. Okay, moving on then, item number 6. So oral briefing, inquiries, implementation programme, management board. So can I refer members to the following papers? We have a briefing paper on page 50 of the main pack and one on page 8 of the table of papers, and we also have correspondence from Neurology Action, that's at tab 8 and page 236. So just waiting on the officials coming in, because they must have been listening to our meeting last week, because there's 6 of them coming.
We'll make sure we don't get 6 answers to every question that's asked, or we'll be here to 10 o'clock tonight.
So can I just welcome Dr. Patricia Donnelly, Chair of Inquiries Implementation Programme Management Board, Mr. Brian O'Hagan, HSC Leadership Centre and PPA Advisor, Mr. Robbie Davis, Director of Healthcare Inquiries Oversight Directorate, Mr. Kieran McAteer, Director of Quality, Safety and Improvement, Mr. Vincent Ramirez, Infected Blood Inquiry Healthcare Inquiries Oversight Director, and Michael O'Neill, Head of Independent Medical Examiner Service Policy Branch. So, thank you very much, all of you. Just Michael sitting at the back, he's in the public gallery and can be called forward at some point.
Sorry, I've sat at this table, if that's okay.
Sorry. There you are. Sorry,
Thank
my
you.
papers leading me astray. So anyway, quick overview and then we'll take questions.
Okay, I'll make a start then. Firstly, good afternoon, and thank you for giving us the opportunity to speak with you today. I'm Robbie Davis, Director of Healthcare Inquiries Oversight within the Department. My colleague Kieran McAteer, Director of Quality, Safety and Improvement, is also in attendance. We're supported by Vincent and Michael, who will cover aspects of the infected blood inquiry and duty of candour, respectively. Also joining us today are 2 independent members of our Programme Management Board, Dr. Patricia Donnelly and Brian O'Hagan. My colleagues and I will take this opportunity to provide you with an update on the work of the Department's Inquiries Implementation Programme Management Board. We will also do our best to answer any questions you may have relating to the implementation of public inquiry recommendations under the coordination of my Directorate. I would like to start by recognising the individual patients and families that are at the heart of each of the public inquiries we are discussing. Behind each inquiry there are a great many individuals, both patients and their loved ones, who have come to grave harm as a result of failures in our healthcare system. These individuals and their families remain in the forefront of our minds. Our key objectives in overseeing the implementation of these inquiry recommendations are to enhance patient safety and to restore public confidence in our healthcare system. A written briefing paper was provided in advance of this update session. Hopefully that has provided you with sufficient background material. In order to avoid the risk of repeating the content of the paper provided, if you're in agreement, Chair, I would like to take the opportunity to highlight a few key points, if I may. Okay, in my most recent verbal update to this committee, I provided an overview of the governance arrangements of the Inquiries Implementation Programme Management Board, including the co-design and assurance arrangements. You may recall I highlighted our intention to provide a consistent departmental approach to the alignment, engagement and assurance requirements relating to the implementation of inquiry recommendations. The Programme Board and governance approach has been designed to accommodate all relevant healthcare inquiry reports with a Northern Ireland dimension. This includes NI-specific and also UK-led inquiries, such as the Infected Blood Inquiry and the Cumberledge and Hughes reports. On the publication of their respective reports, it is intended that the recommendations arising from the Urology Services Inquiry and the Muckamore Abbey Hospital Inquiry will also fall under these governance arrangements. You will likely already be aware that a thematic approach has been adopted to ensure the commonality across inquiry recommendations can be readily identified and to provide a cohesive approach to the delivery of the intended outcomes. As further inquiry reports are published, their recommendations will be considered in the context of the extant themes and work streams to make the most of our opportunities to build upon systems learning. To be most effective, it is essential that inquiry recommendations are considered in the round and not in isolation. From the outset of this process, it has been our intention to ensure that those individuals adversely affected by the failings in patient care have opportunity to shape the practical implementation of the reforms identified by public inquiries. I will take this opportunity to draw your attention to Appendix 1 in your briefing pack, which provides the report into the involvement of the Independent Urology Liaison Group in the INI implementation programme. I'm greatly encouraged by the finding that the collaborative approach was not symbolic, and indeed that it transformed the work from a compliance exercise into a reform process anchored in real-world impact and ethical accountability. This was only made possible thanks to the trust placed in the department by former patients of Michael Watt and family members of former patients who embarked on this journey in good faith and consequently made a transformational impact. The Independent Neurology Liaison Group was established to enhance the department's co-production model, placing the lived experience of patients, families and carers at the heart of scrutiny and decision making. The group's work aligned with the work of the Assurance subgroup to further enhance feedback from the service users, carers and families on the assurance process and implementation programme. The group consisted of 14 members comprising of patients and family members of patients. The work of the group has been completed, with assurance frameworks now in place for each of the 76 neurology inquiry recommendations. Members of the group recommend the approach of seeking and embracing the lived experience of service users and their families prior to the implementation phase of future inquiry recommendations be adopted as standard practice. I am confident that the co-design approach taken with the group provides a blueprint for how we ensure the patient and family voice is represented in the implementation of future inquiry recommendations. I'm very grateful that Brian O'Hagan, co-chair of this group, is present today to take any questions you may have on this approach. On behalf of the department, I also extend my sincere thanks to Mr. Tom Ward, who also co-chaired the group and is not present today. Moving on to a few key points regarding the neurology implementation programme. You will be well aware that the Neurology Inquiry report was published some 3 years ago. The 76 recommendations therein identified a series of requirements to improve patient safety, requiring action not only from the department but also the GMC, healthcare organisations and the independent sector. I am able to advise you that the current position regarding the Neurology Implementation Programme is that 57 out of the 76 neurology recommendations have been verified as implemented. This is following review by the Independent Neurology Liaison Group, scrutiny by the Assurance subgroup and approval by Programme Board. 8 neurology recommendations are ongoing with implementation imminent and are now classified as ongoing and about to be implemented. And the remaining 11 neurology recommendations have agreed assurance frameworks and action plans in place. However, these require some further action to be taken before the recommendations can be verified as fully implemented. These will be subject to further assurance processes to finalise. I should also note that one recommendation 68, will be deferred until such times as the DHSC timeframe for the reform of GMC legislation has been set out by UK Government. I'll now briefly touch on the Urology Services Inquiry. The written paper provided to you on the 10th of June included an updated position on the USI, which, as you will know, was established in September 2021 and is chaired by Christine Smith KC. Members will be aware that the inquiry is wholly independent and not accountable to the Department of Health, and as such it's not possible for the Department to provide a timescale for completion of this inquiry. However, as previously noted, we understand the inquiry is in the process of writing its report. The Department will, of course, consider this report, its findings and recommendations when published in due course. Finally, before I pass over to Kieran, I would like to touch on the infected blood inquiry. You will be aware that the infected blood inquiry was announced in July 2017 and established as a UK-wide independent public statutory inquiry with Sir Brian Langstaff KC as chair. The inquiry published a first interim report in July 2022 and the second interim report in April 2023 that set the framework for compensation. Committee members were last updated on this work in May 2024 as part of a briefing on the Victims and Prisoners Bill, which has been used by UK Government as the vehicle to develop the Infected Blood Compensation Scheme and to establish the Infected Blood Compensation Authority. The inquiry report was published on the 20th of May 2024. It includes 12 recommendations and sub-recommendations, in total 58, which cut across a wide range of policy areas, including quality, safety and improvement and workforce policy, as well as the culture and working practices of the wider executive, civil service and health and social care system. Recommendation 1 concerns the establishment of a UK-wide infected blood compensation scheme. The Department's Population Health Directorate has been overseeing the transition from the Northern Ireland Infected Blood Support Scheme to the UK-wide Infected Blood Compensation Authority, who will take over legal responsibility for infected blood support payments. Healthcare Inquiries Oversight Directorate, which I lead, will be responsible for coordinating the Department's response to the non-compensation elements of the infected blood inquiry. As a UK-wide inquiry, the Cabinet Office has led the comprehensive response to Sir Brian's recommendations, and departmental officials participate in 4 nation working groups to ensure a joined-up approach is taken insofar as possible. As such, some of the recommendations are being taken forward on a UK-wide basis. This is the case for Recommendation 2, which will see a UK Memorial Committee set up to provide a steer on what memorials should be provided and where, including in Northern Ireland. Recommendation 3, which aims at ensuring the learnings from the inquiry are fully embedded within clinical practice and training, is also being taken forward on a UK-wide basis, with the General Medical Council leading on its implementation. There are, however, regional considerations to this work. In contrast, Recommendation 4, which concerns the introduction in Northern Ireland of a duty of candour in healthcare, is being taken forward by Quality, Safety and Improvement Directorate colleagues. My colleague Kieran will explore this with you in more detail shortly. Members will be aware, however, that Recommendation 5, which seeks to expand such a duty to civil servants and ministers, was referred to the Executive Committee in December 2024, and the Department of Finance is now leading on its implementation. Other recommendations will also mostly be implemented regionally under the leadership of departmental officials or health and social care partners. An IBI regional group made up of representatives from HSC Trusts, Northern Ireland Transfusion Committee, Northern Ireland Blood Transfusion Service and relevant policy and professional leads will advise the Department on the best approach to implementation moving forward. The IBI regional group members provide progress updates on the respective work areas, and these have been conveyed to inform the UK Government response to the IBI statements, which were published in December 2024 and May 2025. The regional group will be central to the assurance process, in particular in identifying the areas of current practice that already meet the requirements of some recommendations and, crucially, where gaps exist that need to be addressed. This will be considered at the next meeting of the Inquiry's Implementation Programme Management Board. Stakeholder outreach and involvement are key to this work, and an infected blood stakeholder group consisting of representatives from infected and affected communities and families in Northern Ireland was set up in 2023 and has been meeting regularly since then to impart their views and perspectives. Finally, members will also be aware that the inquiry held additional oral hearings on the 7th and 8th of May of this year, which focused on the timelines and adequacy of the UK Government approach to compensation, and an additional report was published on the 9th of July, formulating 26 recommendations on compensation aimed at providing faster and fairer compensation to victims. These are being taken forward by Population Health Directorate colleagues. I would now like to pass over to my colleague Kieran to provide his opening remarks.
Thank you, Chair. Thank you for the opportunity to provide an update on implementation of recommendations from the inquiry into hyponatremia-related deaths. I'll provide only a brief overview on the background, as I know members are aware, and then an overview of ongoing work. In January 2018, Sir John O'Hara published his inquiry report, which examined the deaths of 5 children in hospitals in Northern Ireland. The report made 96 recommendations comprising 120 separate actions. And Chair, I know today we will focus on implementation of the recommendations, but I think it is important to acknowledge and to remember the origins of the work, which is to address the failings that led to the tragic death of those young children who, along with their families, were so badly let down. The Department established an implementation programme to address the 120 actions. This work was paused in March 2020 due to the pandemic and recommenced in 2021. The current position is that 70 of the 120 actions have been implemented. Of the remaining 50, 15 relate to duty of candour and being open, 4 relate to RQIA functions in relation to duty of candour and in relation to the SAI process, 21 relate to serious adverse incidents process, and we spoke about that last week, Chair. 1 relates to the establishment of independent medical examiner, 7 relate to workforce actions, and 2 relate to issues around clinical negligence and litigation. I would like to start, Chair, with an update on duty of candour. Members may have had an opportunity to see today's statement from the Health Minister in relation to duty of candour proposals. Firstly, in relation to plans for an organisational duty of candour for Northern Ireland healthcare bodies. And secondly, in relation to the Public Office Accountability Bill, which was introduced in Westminster on Tuesday past, and which, subject to agreement, will place a statutory duty of candour on all public authorities and public officials, including those working in healthcare, to perform their functions in the public interest with candour, frankness and transparency. I will provide some detail on each piece of legislation. So in relation to the first piece of legislation, that is the organisational duty of candour for Northern Ireland, this will be a standalone piece of legislation for Northern Ireland only. In high-level terms, an organisational duty would place a legal obligation on health and social care organisations to act with transparency and honesty when there has been an unintended or unexpected incident that results in or could result in death or harm, and to ensure that patients and families are informed promptly, compassionately and accurately. This will bring Northern Ireland into line with the other UK nations where similar duties already exist, and this will also deliver on commitments given in response to the infected blood inquiry, which Robbie has alluded to. The Minister wants the Department to bring forward this legislation as soon as possible and has targeted this mandate. The policy detail of the bill will be developed by officials over the coming period, taking account of the legislation in the other UK nations and lessons learnt there. In relation to the second piece of legislation set out in the Minister's statement today, that is the Public Office Accountability Bill introduced in Westminster, this is proposed to be a UK-wide piece of legislation and is proposed to cover all public authorities and public officials. There are, as currently drafted, some exemptions for parliaments and for courts. The bill is intended to ensure that public authorities and officials perform their functions at all times in the public interest and with candour and openness. It is an element of the UK Government's and the Northern Ireland Executive's response to the recommendations of the infected blood inquiry and in response to the Hillsborough and other inquiries. The bill that has been introduced will deliver a number of different elements in relation to candour and openness. These include that public bodies and officials will have a new duty of candour and assistance at statutory and non-statutory inquiries, at coroner's inquests and at other investigations. The detail of the types of other investigations which may attract the duty has not been described in the bill. Instead, the bill provides a broad regulation-making power which may be used following appropriate consideration and consultation to define in secondary legislation the type of other investigations which might attract the duty. Public servants will also be placed under new duties of candour relating to their day-to-day work. These professional duties of candour will be set out in mandatory codes of ethics at organisational level and will be tailored to different sectors. The bill also seeks to create a new offence of misleading the public. This offence is aimed at addressing some of the most serious wrongdoing in public services and is targeted squarely at those who aim to mislead the public or to cover up the truth. It will not include, for example, accidental mistakes or inaccuracies. Engagement with Whitehall officials and coordination of Northern Ireland Department's considerations of the emerging bill has been led by colleagues in the Department of Finance. The final detail of the draft bill has been shared with officials in the last few days in Northern Ireland and now requires more detailed consideration and analysis. Engagement is also now required by all Northern Ireland Civil Service departments with their respective stakeholders to seek to assess and to understand the full implications of the bill. This is the same for us in relation to health and social care, and we will of course factor in further engagement with the committee chair subject to your agreement. The engagement will inform further advice to the Health Minister in due course. So as I mentioned, it is proposed that the Public Office Accountability Bill will be UK-wide. The Assembly's consent would be required in due course in order for the bill to extend to Northern Ireland. Given the cross-cutting nature of the bill and its provisions, agreement from the Northern Ireland Executive will be required for a legislative consent motion to be brought, with the legislative consent motion then presented to the Assembly for debate. Chair, the broad policy intent for the Health Minister and for the Department of Health is to seek to achieve alignment with the other UK nations in relation to both an organisational and an individual duty of candour. The Minister has acknowledged in a statement today that aligning Northern Ireland with the rest of the UK in terms of duty of candour brings several strategic, operational and cultural benefits for the health and social care system here and promotes consistency and fairness of approach across the UK. Chair, if I may just briefly in relation to some of the other work, and I appreciate a lot of the details in the pack. So we have updated the committee last week in terms of the SAI redesign. 21 actions from IHRD relate to the SAI redesign. Members will be aware also of the regional Being Open framework. The framework aims to ensure that individuals within our health and social care system are fully empowered to exercise candour and openness, and that HSC organisations have in place the necessary support and systems required to enable and to nurture a truly open culture. A public consultation on the framework ran for 15 weeks and ended at the end of March 2025. This included 9 online engagement sessions with service users in line with co-production principles, and a total of 270 responses have been received. The Department has reviewed the responses and assessed the feedback and recurring themes, and subject to Minister's agreement, a consultation analysis report will be published in October 2025. A writing group has been established to consider the responses to the consultation and to make the necessary changes to the framework. And again, subject to Minister's agreement to the final document, it is anticipated the framework will also be published in October 2025. This will be followed by a period of implementation in which the Department will work with trusts and others to embed the use of the framework. The Being Open framework will complement and support implementation of the proposed legislation in relation to duty of candour, which I have just outlined, and will help further embed a compassionate and open just learning culture in Northern Ireland HSC. There are 4 IHRD recommendations, Chair, related to RQIA. These are dependent on implementation of the statutory duty and of the new SAI process, and work will be taken forward under those 2 respective work strands. There is 1 IHRD recommendation related to the establishment of an independent medical service, or IME service. An IME is concerned primarily with 3 functions. Firstly, ensuring that deaths are appropriately and completely reported to the coroner when required. Secondly, when reviewing the quality and accuracy of medical certificates of cause of death. And thirdly, identifying any safety and or governance issues related to deaths and death certification at an early stage. Work to conduct prototypes for a statutory IME service for Northern Ireland has been ongoing since 2020, and this has been a significant undertaking by the Department working with trusts. Further detailed, Chair, is in the pack, but very briefly, the latest prototype started in April 2025 and will identify the implications for reviewing deaths certified in hospital, out of hours and at weekends, and a final prototype that focuses on reviewing deaths in the community will commence in the new year. Once the full implications of these prototypes have been assessed, proposals for a statutory system can be developed in partnership with the Department of Finance, who are responsible for death registration, Department of Justice, who are responsible for the coroner service, and Department for Communities, who are responsible for burial and cremation policy. Chair, this is a significant undertaking and cross-departmental piece of work which will require development of new primary legislation and full public consultation, and will be dependent on resource within the department. So just in conclusion, Chair, hopefully the breadth and depth of the work set out demonstrates that implementation of the recommendation remains a clear priority for the department. There is substantive work underway across a number of policy and legislative areas, and over the next number of months we will see significant milestones achieved. And whilst this work is clearly challenging and complex, and we discussed some of that at the SAI piece last week, it is also very necessary, and with sustained implementation focus can help deliver significant improvements in culture that support openness, learning and balanced accountability across our health and social care system, and ultimately leading to improvement in the delivery of care. And Chair, we will do our best to answer any questions that we can. Thank you.
Thank you very much. There is an awful lot of detail in that, and it's obviously very, very important detail. Our healthcare systems, all our public services, I suppose we absolutely need a cultural, from the organisational and from the individual point of view, where it's all about protecting people, saving people, treating people the way that they should be and the way we would expect. And obviously in the past, because of the number of inquiries we've talked about here, that hasn't been the case. So Kieran, I mean, I suspect a lot of this is going to be, the headline stealer is going to be the duty of candour. So we've just had a statement from the Minister in relation to it. So I'm trying to understand it. So the Minister's saying he plans to bring forward a duty of candour bill legislation in this mandate from an organisational point of view, and that he is going to engage with departments across the water in relation to the Public Office Accountability Bill, which will deal with essentially a duty of candour from an individual point of view. Is that my understanding?
Yes, Chair, that's correct.
Okay, and so the Public Office Accountability Bill will include workers within the health and social care sector?
Correct, Chair, yeah.
Okay. That was pretty straightforward then in terms of that. So, I mean, that's obviously going to be vitally important, and it's obviously, just given what we've discussed today, going to be very complicated. So, he's saying he's committing it before this mandate, but we don't really have a lot of time before this mandate. Can you give us any indication of when we are likely to see that? And this committee be able to start working on this assembly? Because as I say, there's going to be an awful lot of members want to engage on this particular piece of legislation, I would think, and we want to take it very seriously to ensure that it's not rushed and that the outcome is in the best interest of the people that we serve.
So, Chair, in terms of both separate pieces of legislation, then, in terms of the organisational duty of candour, we don't have a definitive project time frame. As yet, Minister has asked that we bring it forward in this mandate, and we will prioritise accordingly. We do have the other organisational duties in the other nations, so we're not starting from a blank sheet. We can learn from what's there already. We can learn from what has worked well and what can be improved, and there has been reviews undertaken recently in England of implementation of its duty, and I think colleagues in Scotland are about to commence theirs. So you're absolutely right to say, Chair, it's a challenging time frame. It will be in the 26-27 mandate year, I would suspect, but certainly the development phase commences now, and as I say, we're not starting from a blank sheet, so we can hopefully do that with a fair wind. In terms of the other piece then, as you say, Chair, in relation to the Public Office Accountability Bill, so we have got the full detail of the bill just in the last few days. The Executive had indicated in March of this year agreement in principle for Northern Ireland to be included within scope, but that was contingent on assessment of all of the detail and any risks associated with the detail. And that period of engagement now with all sectors across all Northern Ireland Civil Department starts now, and for us in health. We would expect maybe, Chair, will be in a position to come back and update the committee further with your permission sometime in October, if that works. But as I say, that will be subject to further engagement sectorally, updating the Minister, a decision from the Executive, and will be brought forward to the Assembly to discuss a legislative consent motion. I don't know, Michael, if there's any further sense of the time frame as it progresses through Westminster. I don't know if I've heard a year, or an apologies, there's a lot of detail coming at us just in the last few days.
I think the working assumption is a year for the passage of the UK wide bill, but in terms of the organisational duty, another advantage we do have, in addition to the fact that we do have organisational duties in the other three nations, is across the UK there are people working on this area at the minute because of the infected blood work. So sometimes when you're playing catch up in relation to some policy areas, it can be hard to engage with other nations, so that should be an advantage in terms of expediting some of this work as well.
So in terms of the public, I mean, duty candour bill, it'll go through the process, the legislative process here. The Public Office Bill, so which department is going to lead on that?
So the Department of Finance has led to date in terms of engagement with Whitehall. There was a cross-departmental working group, and all departments are represented on that. And to date, each of the departments has a sort of a sectoral interest, for want of a better term. So we have focused, for example, on the duty of candour provisions and making sure we fully understand and can break down those. In terms of the full breadth of the bill, there are other areas that are sort of more closely been scrutinised to date by colleagues in Justice or colleagues in Finance. But the DOF is leading on coordination of the inputs, but each department now, with the full content of the bill, will be taking it forward with their own respective sectors and gathering views and assessing implications sectorally.
In terms of the process, departments, politicians here can feed into feed into. But at the end of it, I mean, will this bill come from Westminster and we will be asked to either agree or disagree in LCM without any ability to amend or have specific legislation here attached to it?
So the legislative consent motion, you're right, Chair, I think will be the key vehicle for agreeing or otherwise how politicians sort of here can influence the process as it works through the Westminster Parliament process. I don't know the answer to that in terms of the opportunities. It's maybe something we can sort of look further into ourselves. As I say, the bill does allow, it has some enabling powers and sort of regulation making powers in certain areas which would be brought forward within sort of respective jurisdictions. And again, I don't know the full scope of all of those. I don't have that the detailed recall. As I say, we just got the through in the last few days. But in terms of the overall bill, it will be a Westminster process. It'll be subject to a legislative consent motion with executive and assembly debate and agreement. And any if there were to be any regulations brought forward as a result of the primary legislation, I understand they would be local, or certainly a number of those would be local. I don't know, Michael, if you have anything to add to that.
Yeah, just so the enabling powers then provide powers for Northern Ireland executive ministers to make regulations to extend the provisions. So so statutory inquiries are codified in the bill, non-statutory inquiries, and then the other investigations, and that's where the enabling powers can come in. So that's where the local control can happen in relation to those investigations.
Okay. Thank you. Thanks very much. So I'm just want to get back, Robbie, to you and maybe Brian, just very, very quickly in terms of program management board. So, I mean, in terms of the co-design, which you said is very important, and I agree with it, very important. I mean, feedback with stakeholders. Was there any changes as a result of that engagement?
Yes, there have been significant changes made to the department's implementation of recommendations based on the input of the members of the group, and it's probably best for me at this point now to hand over to Brian and Patricia.
Hi, Chair. Yes, I'm delighted to talk about this, but because liaison groups initially started in hyponatremia engagement piece, where the families wouldn't engage within that for a multitude of reasons. They were very traumatised about it. And the department decided that it didn't want to go ahead without some public involvement. So it recruited people from the health and social care world, service users, carers, etc., that were interested in that, to be a public voice within that. And they, as started through that process, decided that they would work better if they could coalesce around in one group, speak across all the different programmes that were there. And they call themselves a liaison group, and I was nominated to chair that group throughout that time. When it came to developing a process for involvement of people around the neurology inquiry implementation, the department asked me to give them a hand to look at how you might do that, and simply was along the process of we would ask those affected and their families. No one else was exclusive to them. If they wanted to be involved in the first place, we put out a call through the PCC, through the PHA, other agencies where we knew people would get a message. And 23 people, I think, initially contacted us to say they wanted to be involved. I met with each of those, talked through what people wanted from the process, and explained what we could give them from the process, which was a big thing. It wasn't about changing the wording of an inquiry that had already been recognised, but it was how you were going to implement each of those things and how you're going to use their lived experience to be able to identify what knowledge they could add to that. So the group started off from that there, 14 people signed up for it, and they started the process. Patricia Donnelly here was leading the assurance work on that there, which was a separate group which looked at the assurance framework on what you would need to actually implement these, where it would work in the system. And Patricia recognised early on in the process that if she took the least complex ones of those frameworks and worked with the group on them, that it built the group's capacity to understand how the health system worked as we went through it. Because even though these people were experts in their own conditions, experts in their own treatment, experts in how the inquiry and Dr. Watt had affected them, nobody comes to the board with the full knowledge of how a complete health service works. Examples of that are responsible officers. What's the impact of them? How do they work within a system? So the group asked me, as they were going through it, find us a piece of knowledge about that, or tell us how a particular thing. And that's exactly how we progressed. It was incredibly hands-off from the department. They provided a secretariat element of it. From that there, the group nominated one of their own members to be a co-chair, and we were incredibly fortunate. They nominated a guy called Tom Ward. And Tom co-chaired this entire process with me. The success of it is largely down to his leadership within that. And myself and Tom would take the views of the group after they had gone through the recommendations, the original frameworks of the recommendations. They would compare them against what could happen, etc. And we would bring them to Patricia's group, where there was a group of independent people there on an assurance framework. And Tom and myself would argue the case for the group of why they wanted changes. Now, it's a long-winded way of getting around to tell you how the process worked. You wanted to know about the exact changes. The first thing the group did, I suppose, was change language around it. So shoulds and mays into musts, a very proactive way, no ambiguity in what you were asking people to do within the system. The second end of it was probably more to do with understanding the context of patient safety. And that came about very simply by the group asking, when we talk about patient safety in this context, what are we talking about? And it permeated right through the report, and it permeated right through the recommendations, but there was no distinct definition of it. It had about 5 different definitions. There was one NHS definition, there was definitions that were being used in Northern Ireland across different things, and there was a World Health Organization definition. The group scrutinised the definitions that were available and then came back and made the argument that the World Health Organization one was the most robust. It was the one that would carry the most weight within it. They went to Patricia's group and argued the point there, and that it was brought then to IIPMB to endorse that there as the definition for patient safety in Northern Ireland that we would use going forward. Now, that has implications far beyond the I&I work. That also comes out in the patient safety framework. Being Human was launched by RQI yesterday. It was their definition that was accepted. The SCI work that you talked about last week, it was their definition that permeated that, and the Being Open work is their definition that permeates that. The other aspects of this that there was significant change in was the whole pivot from, as Inquiry wrote its recommendations, those recommendations were very functional to the system and very system orientated. And the group realised that you needed to reorient everything back to what it was all about, is protecting a patient in the middle of this. So patient safety should have been the key aspect of this. So having defined a very good, very robust definition of that there and got that into the system, there was a key committee recommended within the recommendations, which was the Quality and Safety Committee. And it has the same standing within the trust as the Audit Committee, so incredibly powerful committee within it. And they recognised that if you had the word patient in front of that there, it entirely changed the aspect of what that committee was going to do and how the public would see it. So patient safety and quality committee suddenly became a focus for the entire system to realise what we were talking about here wasn't just the quality of a system or the functions or the regulations within it, but it was about protecting people at the core of it. So from that, those are just the simplest of things within it. Beyond that, if you see there's sleeping bags with you, I could bore you all night long about every single change of it. But if you're really interested, the group had asked me at the halfway mark to create a benchmark of what they had changed in it, and I wrote up a report on it. And then we concluded the process with writing up an hour report of what they agree with that they have changed within it, right? It is important to say that none of this is done by one group on its own, and it was their co-production with Robbie's team, with Patricia's assurance group, which was the key mechanism in this for change. That's where the change all came together, and that's where the real co-production piece in this and a uniqueness in this came from. And as a result of it, they were nominated for a Penn Network Award for co-production, and they are shortlisted for that for the 2nd of October. So, that group has had wide reach in its impact.
Right, that was a very informative answer, and I'm glad to hear that the work is bearing fruit. It is important in all of this that we learn the experiences from those most impacted. So that is good. Although, given that I'm chairing a meeting and I've allowed it to run an hour behind time, please be a wee bit more succinct in our answers. I'm going to move now to Colin.
Thank you, Chair. Thank you for the presentation. It was very detailed. I'm not sure if you asked us 20 questions, would we remember all the facts and figures that there was in it? It was so detailed. It's just a really quick question. Just in the scheme of the breadth of issues that we've had over the years, where are we benchmarked to other jurisdictions and areas? Do we have it feels living here like we've had more inquiries, more problems, more issues, big issues that are scoping, like I think the neurology report was one of the biggest across the UK, and we have this whole host of things. Is it the same in other jurisdictions? Are they facing a similar number of inquiries in their health services? And if we're ahead of the game, unfortunately as it would be, is there a reason why we are having to face so many issues?
That's a good question, and I think Northern Ireland has had its own specific circumstances that have led to inquiries being called. I mean, the neurology recall was obviously one of the largest in history in Northern Ireland, certainly, and similarly, the urology inquiry was based on the practice of a single consultant. So there have been in Northern Ireland of the past number of years more inquiries than you would necessarily expect. Now, I wouldn't anticipate that's a pattern that we're going to see continuing. Indeed, the purpose of the programme board, as I've tried to set out, is to draw together the commonality in the themes across the inquiries, and in some respects, I imagine when we see future reports publish, in a sense, it'll give us as a department an opportunity to mark our homework and see, well, how well have we learned from neurology? How well have we learned from hyponatremia? How successfully have we given effect to those recommendations? Because we should be reading through improvements and seeing fewer instances and driving down the opportunities for those failures in patient care.
And again, I mean, this obviously, you aren't the people that have created problems or difficulties, you're the ones looking at the inquiry and that, so it's no reflection on yourselves. But I mean, I think of a number of other cases that we have been presented to us where there's a couple of other people who are themes that are saying we want a public inquiry because of difficulties, and I think of the ladies with letters and others that are looking for inquiries, and it just feels that we seem to have an awful lot of problems within our health service that are resulting in inquiries which from the outside looking in would make you potentially a little bit sort of scared, and I really think it's good to hear that we're scoping out what are the commonalities in terms of themes to be able to apply them back in so that the public can have that full confidence. But maybe just one point that I didn't get from me, how are we in terms of benchmarking against other places? Do we have, because if we could have more inquiries because we're granting more inquiries, but we could have more inquiries because we've got more issues. And then you've mentioned there that there may be more specific circumstances that lead to that. What would those specific circumstances be that are leading us to have the problems that are causing the inquiries, and can we fix that?
I know Patricia's keen to come in here.
Well, I think there's probably two issues. One is around openness. And I think if you look at people call for inquiries when they don't trust what they've already got in response from the organisations. So I think the pivot that we're now making in the system around openness and the expectations that public should have and patients should have right from the start of their care about that acknowledgement of where the risks are, the acknowledgement of being more realistic about that, and also being more open about the information where things have started to go wrong or where there is the potential for harm. Health and social care are not without risks, but if we pretend it isn't, then it's a real shock to people when they find that that drug doesn't work or that surgery didn't have this outcome that you expected. So there's something here about openness, and that's why I think that time has come and beyond. And I would hope as that improves and the culture improves, then the call for inquiries is, reduces. So even when I look at the Northern Ireland Public Service Ombudsman launched the complaints thing, which I know you're aware of, in June, and that was about building trust very early, acknowledging that there was harm or there was hurt very early and being open then about that, I think that stops people feeling further harm and hurt, because sometimes they'll say, you've heard it, I've heard it, you know, apology isn't enough. You know, it had to be dragged out of people, and it was too far down the line that it didn't feel meaningful. So you try and amend that and build that trust right from the start, and you answer all the questions that are asked in that. You follow right through that there is an outcome. So the fact that the system is now in implementation phase of that revised guidance, I think you start to improve where there's complaints, you start to improve where there's serious adverse incidents, where things have already gone wrong. And then I think you change that culture completely, and people need to be less passive in their receiving their care, so they expect more. And I think the other thing too, I would say, is there's something about the scale of Northern Ireland. You know, if we think about some of the inquiries that there have been and are yet to report, it's about people who are lone working. And, you know, Northern Ireland can't afford to maybe have a whole team of consultants in a specialty or a subspecialty. It's often a subspecialty where the risks are. And therefore, recommendation 15 and 42 in the neurology inquiry is about how you address the issues around lone working. You need to know when it's happening, you need to mitigate it, you need to control it in every way, you need to monitor it, you need to offer support to the individual, because we cannot afford financially or in resource terms to maybe have more than just an individual working in at a highly specialised area if we want to deliver that service in Northern Ireland. So we need to know, and whereas I think in other parts of the UK and Ireland, they've got bigger teams, they've got the opportunity because of their population size. So I think we have a vulnerability there, but we'd rather have that service than not have it. So therefore, that's part of a risk that we have to recognise and try and monitor.
It's really useful. Actually, that's an element of just that lone working. Actually, that creates, there isn't a peer observation going on around. So there's a certain logic to that, and the openness is crucial as well. And it's made me sort of chuckle inside, because I remember 2 years ago my mother going through an operation, and the doctor stood and it was like they were reading off a list, and it was like 10% might have a complication, 20% may have this, 30%, and 20% don't make it. I was like, okay, well, right. Well, let's hope we're in the first 80% then, and not that 20% at the end. But again, it was just a great way of detailing exactly what the expectation was out of that operation. So if something, God forbid, went really wrong, well, you could have said, well, we were told at the beginning that those risks were there, and then that doesn't mean that afterwards you become resentful. So that openness in delivering care is really important.
And also what the alternatives are, because there may be other options.
Yeah.
I think to move away from that paternalistic, you know, the doctor knows best, and I'm going to tell you what you're going to, you know, this is but you need to understand the options. So I think there's more openness around that.
Thank you, Chair. Thank you.
Thanks very much. Nola?
Thank you very much for coming along today. I was looking back on the table that you provided back in March to us, and I think that was really helpful for us to get, you know, kind of an insight into which recommendations and where some are. So a lot of my questions are to do with those, if you don't mind. One just quick one on it might be quick to answer because I couldn't find if it was implemented. It was recommendation 30 of the hyponatremia inquiry, the confidential online reporting. The last time you were here, last in October or November, I don't think that one was completely implemented, so I'm not sure. It said confidential online opportunities for reporting clinical concerns should be developed, implemented and reviewed. And when we had NIPSO, I think it was, in here, there was then the discussion around the Scottish model of a whistleblower guardian. I think it was in a few weeks after you were in, and it spoke to the importance of that confidential reporting. So I just wondered where we are in either of those.
I don't know if anyone else is going to answer that.
Is it maybe neurology rather than hyponatremia? Is it maybe in the neurology inquiry? Sorry, I maybe got that.
No, it's not. It's hyponatremia.
Oh, it is.
Hyponatremia, confidential online opportunities to reporting clinical concerns should be developed, implemented and reviewed. I don't have an update. I don't know that there's been any substantive work done since the last time we were here on that. I would need to go back and check some of the detail. We have it marked as implemented here rather than not implemented. So I would need to go back and look at some of the papers. Maybe predates my time in this role. I don't know, Brian or Patricia, if any of you recall. If not, we can certainly come back on that.
Well, I think there was issues around the speaking up champions within, so that there were opportunities for individuals, and we have heard so trusts have gone ahead with some of that. The big issue is always about making sure that things are done systematically and there's kind of consistency right across. So there has been quite a focus on this, and what some of the trusts, and we just heard a presentation yesterday from the Western Trust, which I must highly commend, and they were tracking all of the whistleblowing. That they were encouraging the whistleblowing, and so they were seeing a general rise in that. But what they were also tracking was an increased number of people who were not holding on to their anonymity. They were prepared to actually step forward and name, and that's when it really becomes meaningful, because then it can be investigated more fully, because you're able to track right through and get more information from the individual. So I do think there are initiatives, not exactly, and I would make the point that I've maybe made many times in the past about the hyponatremia recommendations. Sometimes when it came to implementation, they weren't implemented exactly as written, but they were implemented absolutely as intended. So it was looking at the intention of the recommendation and making sure that the system's in place. So I do think this is a space where there's further work that's going on, but there is quite a bit that's already underway within trusts.
Well, I could maybe do a written question about the review of that, just to give more time, because it's on.
If I could just add quickly, apology, there is absolutely a raising concerns policy in place. There is whistleblowing arrangements in place. The department had refreshed, I think, only last year its raising concerns policy, and I know that it is active and monitored by trusts' internal governance. Whether or not it stipulates the exact wording, as Patricia said, and I'm not sure.
But worth adding to that too, that the Being Open framework that's coming out will build a whole cultural change around that. That's the piece that has always been the difficult aspect of that.
Yes, that's my next question, was to move on to the Being Open framework, because many of the actions from neurology and hyponatremia aren't implemented because either duty of candour or waiting for this Being Open framework, and it closed in March there. So where are we with it? And with regards to the actual change of the SAIs, how much is, Brian, like your feedback actually fed in to the significant changes? We're very keen for a committee to actually see, the change that this framework is going to do, but we haven't got information in front of us.
In terms of where we are, maybe with the Being Open framework, first of all, as you said, the consultation closed in March. We're hoping to launch the consultation analysis report and an updated framework in October of this year, and that will be followed by a period of implementation support with trusts. And the Being Open framework, as you've indicated, will be key to the cultural journey around openness. It has been roundly welcomed in the consultation responses. There's broad approval of the intent and what it's designed to achieve. There's broad approval for the way the document is structured in terms of how it sets out routine openness with a focus on learning, and openness when things go wrong. And that latter tier, when things go wrong, as you rightly say, relates to the SAI process. And again, the SAI process is big on and very clear on compassionate, open, just learning culture, systems-based learning, blame-free space and psychological safety, so that staff can come forward and engage in learning, for the purposes of helping understand what has gone wrong, and engaging with the family and helping the family understand what has gone wrong, and importantly embedding learning. So the Being Open framework will focus on those things. In terms of changes in the SAI process related to feedback from service users and patients and families, again, there's a long sort of history to a lot of this work, building on the IHRD work stream, building on the RQIA report, and all of the rich sort of patient family data came through that. We've also, as I said out last week, we've also established our own process as a part of the SAI redesign work. We have recruited service users through an open recruitment competition. We have engagement platforms. I think it was 30 people applied for that. 3 are on our programme structures. The other number we have engaged a few times with. We've also engaged with the PCC platform, and all of that involvement work is set in the context of a wider programme of engagement and involvement sort of across our service, with trusts, with boards, with other stakeholders. So in terms of how that's been translated then into the framework itself, I mean, the framework and the standards have a core focus on engagement with families, patients, service users in a compassionate way, in an open way, early in the process, in line with their wishes. So there is a substantive...
It'll be up and running then, the new...
So the new the SAI framework, we're hoping to publish in November of this year, and that will then commence a transitionary phase. I think we set some of the detail out last week.
And just on the Hillsborough law then, has the department or the minister given any feedback that the department would be supportive within the executive to sign on to an LCM for Northern Ireland, and then if that's passing through Parliament and it's mostly based around an individual duty of candour, how will the previous research that has gone out around the organisational duty of candour that has said it doesn't work feed in? I mean, there's been a lot of research that has said it doesn't work. So if the Hillsborough, or I can't remember the proper name of it, but the Hillsborough law as it's known, focuses on the statutory duty, and we must be clear that it is not about accidental mistakes, it's about deliberate cover-up and misleading. How will that inform the department on whether they actually go ahead with the organisational duty?
There's a couple of things in that maybe. So just in terms of the departments and the executive's agreement to an LCM. So the process to date has been that in March of this year the executive agreed in principle, and then we're at the stage now where the detail of the bill has come through. There will be a period of discussion and engagement, and that will be subject to executive approval and assembly discussion. So we'll go through all of that.
Your department has had haven't decided yet on what.
So,
the Minister hasn't decided yet on his view?
No, because we've only received the detail of the bill in the last few days. Okay. The Minister was content that we were agreed in principle to go along with the bill in March of this year, but Minister O'Dowd in his response at that time on behalf of the Executive was very clear that a full legislative consent motion would be contingent on an assessment of all of the detail, etc., and engagement at this stage. In terms of the organisational duty of candour then, so we'll bring forward the standalone piece of legislation. As you rightly say, in England they have undertaken a review of the application of the review of the law. I don't think they're minded to fundamentally change the legislation at this stage, although it's only interim findings. But there is some lessons to be learned absolutely in terms of the application of the duty, the understanding of the duty, the spirit of how it's applied in practice, compassionate engagement with the families. And I understand as well colleagues in Scotland are reviewing their duty. So there is absolutely rich learning for us and how we can sort of improve the bill as we bring forward. Michael, I don't know if there's anything you want to add to that.
Just the point about alignment, really, in terms of essentially the Hillsborough Law Bill, the Public Office Accountability Bill, is coming in across, or the proposal is that it would come in across the UK that already has in England, Scotland and Wales an organisational duty of candour. So in terms of alignment, the combination of those laws will work. So that's why one of the things Minister is keen on is alignment for Northern Ireland, both in terms of organisational and individual duties.
I've read it was when it was laid the other day, and I've read briefings from legal on it and legal professionals on it, and there isn't a great deal of commentary around the absence of the organisational duty of candour here, and if it isn't working anyway in England and Scotland, and we are very time pressured, and if the full report comes out of its review saying like it is so fundamentally flawed that actually it still isn't holding individuals to account, will the department take cognizance of that and not move forward with the bill here?
So the Infected Blood Inquiry has made a recommendation that Northern Ireland should bring forward an organisational duty of candour because we're out of sync with the other nations, and the Department has responded that it will do that. And the Minister has stated publicly that he's not content that Northern Ireland's outside of the other nations in that regard. As I say, and I'm not over all of the detail, I think the interim findings from the review in England isn't that it is fundamentally flawed, as you indicated there, but that there is absolutely learning in terms of the application. Again, I don't, and as I say, colleagues in Scotland and Wales are about to engage in that. As Michael said, the Hillsborough law does focus on public officials and public authorities, and does have, as you say, attract that criminal sanction as well. So the organisational duty we will bring forward in line with the infected blood, and we will learn the lessons from the other nations. That's what the Minister has asked for. And indeed, the feedback from the Being Open duty of candour consultation, again, has indicated strong support for an organisational duty of candour.
And did it have a strong support for individuals as well?
It had support for individual duty of candour. I think there was around 70%, and around, Michael, if I'm right in this, maybe, and apologies, we haven't analysed all of the figures. There, I think it was support as well from the Health and Social Care Service for the individual, I think, but there were reservations expressed, and members will have heard from BMA and other colleagues around the application of the individual duty of candour. Having said all of that, the ambition for the Department and for the Minister is alignment in terms of the organisational and the individual duty of candour, which will be achieved through the Public Accountability Bill across the public sector and within healthcare. So we won't go any further or have any less of a stringent regime.
Thank you. I think this has been very helpful.
Thanks. Danny?
Thank you, Chair. There's a lot of information there, and we've covered a lot of areas with the questions. I think it is important just to highlight that these inquiries, reports, and recommendations only exist because of the dedication of campaign groups over many years, patients and families who have suffered harm, lost loved ones, and that we have them to thank for making the health service safer for everyone else. We've went through quite a few different themes there. I just wanted to go back to the duty of candour. And would it be fair to say that the lack of openness and transparency is a common theme through all these inquiries, and that the need for a duty of candour was a common, possibly the most common recommendation?
I think that is a fair comment, and I think Patricia and Brian might wish to come in on this as well. It's absolutely a theme in IHRD. It's a theme again in infected blood, and it may well come through in other inquiries that are still to report. And I think the breadth of work that the Department and the HSE is undertaking in this space, including SAI, including NIPSO, including the Being Open framework, including the Patient Safety and Quality Committee, and the whole host of implementation of the other recommendations, and now alongside the duty of candour legislation, I think that sort of signifies and underscores the significance of the issue. So I think that is fair to say it has come through as a theme in other inquiries. I know, Brian, Patricia.
Yes, candour is a major issue because a lot of the recommendations focus on things that were already in the system, but that people didn't do, and then as processes went through, they omitted to mention that they didn't do those things. And that's a theme, not just in the Northern Ireland context, it's a theme right across the UK. It is people stopping information flows about wrongdoing and patient safety incidents that causes the vast majority of inquiries. And your question earlier about inquiries, that we have more here than we have in the UK. We probably do because we're a bit more cautious about getting to the truth, and as Patricia's mentioned, about mistrust of systems. But the implementation rate of what comes out of our inquiries here is a lot higher than it is in the rest of the UK. There's things still lying around from the Francis report and haven't been implemented, etc. So it isn't necessarily about how many inquiries you have, it's about what you do with the information, how you implement it, and how you do that change. The cander piece has always been difficult. I sat on the duty of cander section work stream for the IHRD piece initially. I was very pro about having both of them in place. We put our recommendations towards the Minister at that time in the culmination of that work. There is a difficulty about individual duty of candour. It's recognised that it would set us apart from the rest of Europe, not just the rest of the UK, but the rest of Europe in the context that we'll be beholden people. I think there is some value in bringing forward the Hills work. I think all public officials should be accountable in that way, individually and organisationally. But it was interesting when we talked to this with the I&I group about, Peter McBride talked to them about the being open policy and the cultural change aspect. And they recognised very much that the organisational duty would have been the one that would have had the most impact for them at that time in holding officials to account about the cover-up around their failure to identify what Michael Watt had done wrong and to admit to the system what he had done wrong and in good time to stop any more harm happening. So that is the balance of public opinion on it. It swings both ways. There is accountability for the individual and there is accountability for the organisation. But it must be remembered, as was said earlier, Justice O'Hara said repeated occurrences. He was talking not about people misspeaking at a time. He was talking about people actively, deliberately going out of their way to attempt to cover something up in a public inquiry or public statements, etc. That's the focus of that. And it would also have been the focus of the individual one. So he was talking about those individuals in those inquiries. I think some of that would be covered by an organisational duty anyway.
I'm conscious that we don't want to get into the actual discussion about the legislation. We will have that conversation and as we go through the process. I just want to not stop any of the discussion, but I'm conscious that we're running way late. So,
can I make one final comment, which I think, as you've understood it, the duty of candour happens when something pretty catastrophic has gone wrong. But actually, the biggest thing that needs to change is the cultural piece around being open, and that people feel that they can speak up and they can notice, be curious about what's happening around them, because the biggest protection that we have is our staff, and the staff that can notice when there's a risk and speak up about that risk before it actually causes harm. So we don't want to have a punitive system that is only looking for blame, but it's one that's looking for learning. So I think that's really, we'll not have the issues in candour if we've already got an openness culture.
I think Chair, as well, if I could add very briefly, I think Brian makes a good point around implementation of the recommendations. We clearly are undertaking a lot of activity to implement the recommendations here. There was a review undertaken last year, I think, by England, because they, in the English context, they recognised that they had so much inquiries, so many recommendations outstanding, so much overlap, and they really wanted to cut through and understand why that was the case. I think, Chair, just very briefly, I know we're concentrating on inquiries and rightly so, but it is probably, we'd be remiss not to say that there are thousands of interactions each day across our health service, and the vast majority of those deliver good outcomes and good care. And I think we should, I know members have acknowledged that on many occasions, but I know the context is inquiries, but I think that's a very legitimate point as well.
Right, Danny.
Thank you, Chair. It's certainly good to hear that the implementation of recommendations is higher here in Northern Ireland. So that's certainly something positive that we can take away. But you can also see why there might be a lack of trust in the system when things go wrong, given that we have had all these scandals and the need for these inquiries. Given what the Chair is saying, I had a question about the new offence of misleading the public. I don't know if you'll be able to tell us much about that today, other than it's coming. Is that?
So yes, there's provision in the bill for the provision. It will apply across subject to the necessary agreements. It will apply across all of the public authorities and the public officials that are caught within scope. I'm not sure. I'm just sort of checking. Michael, have you anything just pertinent to add?
Just that was a provision that we've only very recently seen. It really is meant to focus on misleading the public at a very general level. so very widespread misleading of the public, as opposed to misleading a member of the public on a specific issue. So it is the kind of, you know, Grenfell, Hillsborough type issues. But I think just in terms of the detail on that particular issue, it's something we'd want to focus on, if you don't mind, in a number of weeks when we've had the opportunity to consider the detail of the bill.
No problem. And just one last question, just about the being open framework. When does this go live? When are we likely to see
So
that?
we're currently finalising the analysis of the feedback and updating the framework. We are hoping to publish in November of this year, and then that will be a period of implementation support with trusts in terms of how they embed and make best use of the framework. But we're targeting November of this year.
Okay, thank you. Thank you, Chair.
Thanks, Danny. Dan?
Thank you, Chair. Just to build on the sort of line of question that Danny was building on. So I'm interested in the interaction between the being open framework and the bill on an organisational duty of candour, and how that actually worked, because there's a lot of talk about the being open framework, but we've spent hours in this committee talking about the Belfast Trust and all the issues that are there. And we've had numerous reports, and people there who are responsible for the being open framework are within the trust working on it. But we don't seem to have a lot of being open, if you understand what I mean. So I'm interested in the kind of interaction between that framework and a bill that would address an organisational duty of candour. I suppose the other element that I wanted to look at was on Monday I asked the Health Minister a question about the review that was to be carried out into the handover of the maternity hospital. And he said something that was very interesting, which was that the review wasn't carried out, and I'm paraphrasing his words, and just so, because some member of staff didn't cooperate. Will there be? I mean, clearly, again, we're talking about being open, but the bill then will there be some element to make staff or compel staff to cooperate? I'm just trying to, I didn't quite understand what the Minister was saying. I genuinely didn't quite understand it, and tend to ask, believe it or not, more questions in the spirit of being open. But I mean, it seems to me that you can't just simply discontinue a review because somebody didn't cooperate. Is that a thing?
I'll maybe try and answer if that's okay, and then others maybe want to join in. So in
If you can bring any light to that, that would be brilliant.
Oh, well, I'm not sure I know the detail of the specific query around the handover of maternity services. The bill won't deal with that as it's currently constructed. So if we're talking about the Public Accountability Bill, it will have a duty of candour and a duty of assistance in a statutory inquiry, or a non-statutory inquiry, or a coroner's inquest. Now, there is a provision to set out other investigations and define other investigations where the duty might apply.
So can I be really rude and interrupt? So it's not about a general duty of candour, it's a duty of candour in a specific situation. Is that,
So
I picked that up right?
So that is correct. It's a duty of candour in, as it's currently written, it's a duty of candour in statutory inquiries. So those sort of higher end inquiries in line with the 2005 Inquiry Act, in non-statutory inquiries, which a minister may call, in coroner's inquests. So they're the sort of higher end, for want of a better term, sort of inquiries and inquests. There is provision in the bill that respective ministers may want to set out other investigations where they want the duty to apply. Now, there's been no real discussion around what that might mean, what it might mean in across the public sector, what it might mean in the healthcare space. There's an enabling power to set out in secondary legislation, but that will require a depth of consideration and consultation and ministerial discussion with local stakeholders. So there is the ability.
So sorry.
Yep.
So the bill is constructed is only going to apply at a very, very high level within a legal process that's already set up. Is that right?
Yes, as I've described those provisions.
Yes.
Now there are other separate provisions. So the bill also requires.
So just help me with I'll give you an example. Tell me whether the bill would apply. So in the Southern Trust, 17,500 women had smears recalled. We know that the Trust did not correctly monitor the performance of screeners from 2008, at least until 2018. We know that 2 women have died, and we know that a number of other women have had SAIs because they have now been diagnosed with cervical cancer. How would the bill treat that?
I'm happy to touch on that one, Kieran.
Sure.
Just so that we kind of understand the parameters of the bill.
On the face of the bill, because that's not a statutory inquiry or a ministerial-led inquiry,
won't affect it.
It won't. But the minister will have Northern Ireland ministers across the board will have a power under the new law to extend the provisions to the likes of that if that was so desired. So it's not on the face of the bill, but it provides a power that we don't currently have. So it gets us to the stage where we can then make secondary regulations if a minister in the future wanted to extend the power in those circumstances after consultation with stakeholders, etc.
Maybe 2 things if I can just add, if I've just sort of stepped through them. The organisational duty of candour will require organisations to be candid when there is a notifiable incident. Now we will define all of the detail of that, but in line with the other nations, if there is an incident that has an unintended or unexpected outcome and has led to serious harm or death, then that in the other nations constitutes a notifiable incident, and there's a statutory duty to report that, to the family and offer an apology. So it will be captured, that type of
So that
scenario
will be captured under the local
that would be my
organisational
yes, in terms
duty
of
of candour bill. What about actually then making individuals comply with the investigation within that scenario?
Could I just come in now, because this is a live discussion we've had around neurology and the being open work, and what you're talking about is at the nub of it. During the INI and IHRD stuff, it was identified that organisations waited for professional regulators to deal with something as opposed to dealing with it themselves. And you've hit exactly what the problem is. Their contractual obligations should have been enough to remove someone if they didn't cooperate. You have the whole of the HSC has a value which they all ascribe to whenever they sign up, which is honesty and openness. You know, it's one of their 4 core values. So through that alone, an organisation could hold somebody to account and dismiss them on the fact that they weren't being honest and open.
To be honest, I just don't understand what the minister was referring to, so I'm not really that focused on it at all. But I'm just, what it struck me was. Are we in a situation here in Northern Ireland as of now where people are not obliged to comply with an investigation? And will the being open framework or the organisational duty of candour or the latest from Westminster actually help us to resolve those situations? That's really what I was trying to find out.
Well, I should say that there are a number of IHRD recommendations that are there to support both openness and duty of candour, and it's where organisations will then have explicit in employment contracts that the individuals have to be candid, and it also covers whether they don't omit information, and that there's another provision around identifying and cooperating serious adverse incidents. So I think that's how you start to be able to deal with that at an organisational level, and that you hold the individuals to account. I can't speak for what the current and that situation that you're describing.
No,
but
I don't really understand it either.
But very certainly those things only work when the bill is enacted, and then you've got the regulator has a part to play, and then the trusts themselves have a part to play in terms of what they then include in an employment contract.
So if I can just, I know they've thrown a lot of different provisions and standards and things, but the Westminster bill does have other provisions that are relevant here as well. So the bill will require Public servants will also be placed under new duty of candors in relation to their day-to-day work through codes of ethics. The bill will require all public bodies to establish a professional duty of candour for its staff, not regulated professionals, a professional duty of candour for its staff. These obligations will be underpinned by a new duty governing public bodies to promote the ethical conduct of their employees. So that's a second tier to that. And then third tier there, employing authorities will be legally required to set out consequences for staff who do not comply, including potential disciplinary sanctions up to and including gross misconduct. So there's a number of sort of building provisions there. The organisational duty will capture it. Professional standards already captured, and I don't quite understand, as you say, the context of the other one. There's what Patricia has outlined there, and then there are other provisions in the Westminster Bill for professional duty of candours around day-to-day activities, and that employers must put code of ethics in play and must set out the sanctions required for non-compliance with that. So they are new statutory provisions to the Westminster Bill.
So even so there will be the top level, but there are a tier of levels within the bill. Are you going to come back to brief us on the bill, sort of as you get more in-depth information? Because I think that would be really, really important. I think it's an area I think we all want to see, because I'm sure everybody in this committee has talked to people and been emotionally connected to people who feel harm. And it would be really important, that we get the information that helps us decipher what the bill is doing, how it's progressing. And I'm presuming the next Westminster election is 29, so it has plenty of time to pass, hasn't it? Yeah. So anyway, thank you very much. Thank you.
Okay, thank you very much. That was a very thorough assessment of very important issues, and I have no doubt you'll be back. You'll certainly be back, hopefully very soon, Kieran, in relation to the duty of candour and all this other stuff as well. So thank you very much.
Thank you.
So, I'm just thinking, just even in terms of Diane's last point, could we write to the Department of Finance and just ask about the process and consultation with committees, particularly around the health aspect of it, just so that we are fully aware of any role that we will have, but more importantly, the process and the information and the impact that it has on healthcare workers.
Can I just say that in that, and I'm sure you'll do that, is that I would like to welcome the news of the introduction, of the bill, because I think the executive should support it. But I know that they'll all be deciding. But I don't want it to come across as if because I realise that maybe some of my question and others made it sound like from a negative point of view, but actually I think that the Hillsborough law is a positive thing for all public officials. So I don't know if we can make it more of a positive. We want to feed into it.
Absolutely.
Yeah.
I mean, the key aspect of all of this is that people who use our services are protected. We just want to see the details so we can ensure that it's good legislation.
Yeah, I agree with you. I think that the bill is positive. I think that we do need something that actually gives us a bit more oomph and I understand the being open framework, but I'm not sure it will deliver, everything that we need. So I do, but I think it's just when this is thrown out this week that we get to understand the whole processes behind it. I think that that's really important.
Or just as well, maybe that age-old thing, reminding groups a 10-minute presentation at the start, and maybe just like to go light on the figures, because it was just a 20-page readout of a report that was just, it wasn't I looked at one point and I think everybody in the committee was on their phone or their computers, and 2 of the 4 on the screen had switched off, and actually I'm sure it gets to the point where even they look and go, they're just reading it out and nobody's listening to them.
I think moving forward, particularly if we are presented with
We had it all
papers,
in front of us. Yeah.
you know, I mean, we've read the papers, so we don't need to hear it twice. I mean, what the purpose of those I mean, that was very important, and it's always very important. I mean, I'm conscious that people coming before us giving evidence, they want to get as much information across as possible, but we just do need to focus on things that we haven't seen.
It's very difficult if somebody's just reading something out to you to try and retain even what they're saying. It's not fair in them reading it out, and it's also not fair in us to just listen. It's like somebody in the corner with a book just reading 20 pages of it, whereas if the conversation was excellent and they were very detailed and they were very knowledgeable and we got some really good stuff, but we just didn't need that 25 minutes at the start.
On board. Okay, so members, moving on then, item 7, SL1, recovery of health service charges amounts, regulation NI 2025. So page 190 of our main pack. So this is an SL. I have to say this was all new to me. I didn't know the health service had this power. So it's an SL on an annual regulation that comes through Department to provide an annual inflationary uplift to the charges to recover the costs incurred by hospitals in treating casualties of road traffic accidents. So these charges are mainly paid by insurance companies. They are collected on behalf of the Trust by the Compensation Recovery Unit. So this is something that comes before us, comes before the committee regularly. This is just about an uplift. So are members content with the merits of it? Yep. As I say, I didn't know that Trust could claim through insurance for stuff like that, so it was every day is a school day. Okay, correspondence. Can I refer members to the correspondence pack? So there's a number of things there, and the committee have outlined, or the committee clerk has outlined sort of the recommendation. So can I ask people to look in particular at page 8, tab 8, 238 of the main pack. There's correspondence from Protective Mothers NA. I'm just wondering if members have any kind of comments in relation to that. Everybody happy?
1 second, sorry, Chair. I'm just
opening my correspondence too here.
Wait a second.
The recommendation in the it's just to note it. Mm-hmm. So I mean, it's just to note unless anybody has any particular comments they want to make. None. So just then there's correspondence from the department regarding the Royal Maternity System decision, the independent review. So that's at page 14 at table papers. So I mean, it's basically the minister confirming that.
Come in on that.
Yep. It's essentially the minister confirming that the option of the trust is the option. He had wanted to look into that, and it's not great news for. It's not great news. It's 26 months. So Dan, you wanted to come on that?
No, I do want to come in on that because what the minister seems to be saying is that his review has concluded that the trust decision making process, etc., were fine, and that their conclusion was also fine. I think that it would be wise possibly to ask the trust, I don't know when they're back in, genuinely don't know, it would be wise to ask the trust to outline that, because we only got this in relation to a question I asked, I think in June, where they kind of gave it as a bit of an add-on. And I think it'd be wise to ask the trust to let us know that, or maybe to come and explain that for us, and to give us an idea of both time and cost, and also to let us know where the liability for that cost would lie. So I
suggest in the first instance we just write to them, because we're I know from my conversations we're kicking a lot of presentations down the line, so we will have the trust. They're coming and scheduled over the autumn months. So in this instance, we write to them, get that, and we'll have that in advance of when they come, and then we can question them further based on their response. If you're happy enough with that.
Well, I think it would be better to question them, but initially, at least, if we get a baseline from them, because I think that's the minister saying, my independent people have said you can go ahead. Therefore, the decision is not with me. But
I kind of read. I thought it was that the trust had told us that they had their process to find out what was wrong, and there was a couple of outcomes. The minister said that he didn't have faith in their review, so he got an independent review. So now the independent review is saying actually the trust were right. So we're right back to where there was like three options. One was a lot of money, one was a bit. So we're just right back to where we were anyway. So I don't know if we've come any further forward. So I think the chair's idea maybe about getting a written submission first instance, because I don't think we're anywhere where we weren't.
Certainly do need to calculate the issue of cost and liability.
Absolutely. And I mean, that's an issue that's not going away. Like, it's
just need to know when's it going to start. Like, when are we actually going to get in there and
do it and get it
start fixing it?
And how long will that actually
months.
take?
Yeah.
They had the three. They told us the timeline, and then I think in terms of cost, they said that it would be
26 months.
Between them
26 months for the option that they're now going to recommend.
Yeah. That's what I'm saying.
He said that in chamber, yeah.
So another 2 years.
Yeah, that's
more than 2 years. Yeah. I mean, and that's from when they start.
Sorry, Chair, just to come in there.
Absolutely.
Yeah, well, that's.
I think it was in relation to a question I'd asked him in the chamber during question time. I think in June, and I think the answer was 26 months and several £1 million.
Yeah.
Right.
I have heard
that's the kind of answer we'll
that
get
it's
from
in
the
the
trust.
region of £9 million, but I'd really like someone to verify that, and I'd really like the issue of liability. And 26 months, that'll be almost the guts of 4 years after we took the building.
Yeah.
Wow.
I mean, it's a shocking situation that just continually gets more shocking.
Worse, it does.
Am I imagining, did we not see that written down somewhere where there was the three different options,
We did.
the three different timelines?
No, I don't know, did we?
I think we remember seeing that, and then it was based on that he had said, no, I'm going to get a check done on it. But in terms of liability, they suggested that until they had done further investigations, they wouldn't be able to work out where the liability was, and we weren't happy with it at that stage. But
I imagine there's a lot of legal work going on in the background to make sure that everything's, because that's the last thing we need is further.
Postscript, it's good to see that Belfast Trust is getting something right.
Okay, so in terms of the correspondence list, then are members content with the suggested actions? Okay, good. Any other business? None. Date, time, place, next meeting, Thursday 25th September, room 29, 2 p.m. Closed session. Sorry.